Welcome, everybody. This is the Tuesday episode of My Last Relapse with Dr. Shah and Matt. Today we're talking about opiates,
An opiate use disorder.
opiate use disorder, neurological effects, all the good stuff.
Yeah, so we'll talk about just an overview of what we're going to be talking about. It's going to be the opiate use disorder. What does that look like? What does it mean to actually have the opiate use disorder? What are some of the things that you see during your actual drug use, which I think I'm going to get from you a lot,
Hmm.
right? Like what the culture of that is, and I'm actually really interested in hearing more about that. And then we're going to talk about withdrawal, what that looks like, some of the medications that they have for treatment of it, and then just whatever else comes up. Okay?
Okay, sounds good.
Yeah. So, like, we just talk about like definitions first, right?
Hmm.
So, opiate use disorder, there's a difference between like opiate use and opiate use disorder.
Okay.
Opiate use is just, I'm taking opiates as prescribed. There isn't any chronic brain condition that is occurring based upon the dependency of it. So what happens is that when we start getting into opiate use disorder, I'm not using it for the pain management side of it. I'm using it for the euphoric effects.
Hmm.
So the really interesting thing that happens with opiates is that if I actually have legitimate pain, I'm not going to experience the euphoric effects of the opiates
Really?
because there's a signal going down that says, or there's a signal going up that says I'm in pain, and there's a signal going down from the opiates, right, which is blocking that. But if you don't have that signal coming up, that's when the euphoric effect starts happening.
Okay, so I have had surgeries,
Okay.
right? And so I had four wisdom teeth removed at the same time.
Okay.
And then I got dry socket because I was smoking.
Okay.
And I was in incredible pain,
Okay.
like incredible pain. But I was also strung out on heroin, and so the pain never went away. Like, and I was on a heavy dose of opiates.
Right. I mean, but by that time, when you had your wisdom teeth taken out, right,
Hmm.
were you already opioid dependent?
Yeah.
Okay. So what I'm talking about is when someone goes in for a legitimate procedure,
Hmm.
is opiate naive, right? They're not going to get
Okay.
the euphoric effects of that
Yeah.
when they're actually in pain.
It's so.
So the issue that comes up is after you like, so let's say you were in the hospital, you got your appendix taken out,
Hmm.
and the doctor prescribed it for 4 or 5 days.
Hmm.
So for those 4 or 5 days, when you were still in pain, right, you wouldn't get the euphoric effects of it. But as day three rolled around or day four rolled around, and the pain started diminishing, and that signal wasn't going up, and you started taking the opiates again, right, you would get the euphoric effects from it.
Okay. So one thing that's always confused me is people seem to be able to take a drug as prescribed, an opiate as prescribed, and not get like physically dependent on it, even if it's like 10 days of Vicodin. It's
Right.
like they stop and then they're fine.
And so this goes back to the idea that how much of it is treating physical pain versus the emotional side of it.
Hmm.
And so once you stop using it for the physical pain and you start using it excessively for the euphoric effects of it, then that's when I'm looking at opiate use disorder.
Okay.
Right? So that's how because opiates weren't designed for you to like numb out your feelings.
Hmm.
That's not the point of that, right? It was to numb out any of the pain that you were experiencing. But as soon as you start using it to numb out any of the emotional pain that's going on, like I can see how that can be a really slippery slope.
Why is like SUD or OUD? Why is it not a like OAD? Because I was never.
OAD.
Yeah, look, instead of use disorder, it's abuse disorder because I never used. Use wasn't my problem, it was the abuse.
So it's
So it'd be.
all I'm thinking about the nomenclature, right? So the nomenclature is there is it's a use disorder, right? But there are in the ICD-10 codes, it does say abuse also, or like alcohol
Okay.
abuse with withdrawal, or alcohol use with withdrawal. So I think they kind of use those terms synonymously.
Okay.
Yeah, but the whole point is once we get into altering the reward system and the stress system, there's a loss of control and cravings start to increase, right? And so there's a huge spectrum that's involved. And mainly what's happening is that there's a neuroadaptive compulsion that or component that occurs with it, and it's treated as a chronic illness. And so once you have or you've been diagnosed with opiate use disorder, it's not that it's ever going to go away. It's that we have to then start treating it because you've gone down that particular path already.
Okay.
And you start building these pathways that are like, oh, like this feels really good. Um, I was gonna tell you a story, but then I was like, I have to like watch out for HIPAA stuff, right? So I can't tell you the story that I wanted to tell you for fear of HIPAA violation. So I'm gonna stay away from that one.
Okay.
But let's just say that I've had multiple patients that are using that have had a history of opiate use disorder, and they are petrified of taking medications for legitimate reasons.
Mm-hmm.
And I can understand that. We can talk about that later. Let's talk about it now.
Yeah.
And so what I tell those patients is that it's really important for you to have a plan around that.
Mm-hmm.
Like what is your plan for when you go to surgery? What is your plan for when we are introducing these things back into your life? Because I don't want you to suffer and be in pain if there's a legitimate reason. Like if you've had surgery and you've had spinal cord surgery, I'm like, yeah, by all means, right? Like, let's go ahead and give you the opiates for the next like 10 days.
Mm-hmm.
But if you're taking it for like, 20 days, 30 days, I'm gonna be like, oh, like, do we still need that at this point? Like,
Yeah.
or can we handle it with ibuprofen and Tylenol? Right. So that acute setting in the pain side of it, I'm like, that's fine. Like, that's okay for 3 days or 4 days. As long as there's a plan around it and that you're not the one that's in charge.
So, how do you handle that? Because you're an addiction medicine specialist, you're not a surgeon, right?
Right.
Let's say you have a client that's going in for surgery. You would handle that plan in conjunction with the doctor or no?
So I would instruct them on what to tell the physician or
Okay.
what to tell the provider in terms of what they should say to him. And so have you ever read the P11 pamphlet?
Oh, yeah, for A.
Yeah.
Yeah.
So it's the P11 pamphlet is the AA stance on prescription medications. And I really loved that pamphlet. And I went through, so when I was probably my third year of sobriety, one of the elders at Lambda asked me to lead a P11 meeting.
Mm-hmm.
And they wanted me to do it for 2 months because they saw like there was these issues going around with people that were on medications and like they didn't really know. And they were like, let's just get this doctor guy who's like gung ho about recovery to lead these meetings.
Yeah.
So that it wasn't going to be just a lot of the P11 meetings that you find are just people going in there and saying, hey, I'm on this drug, this drug, this drug, and this drug, right? And they get relief from that because it's shame reduction. And they have like someone else to like talk about what meds they're on as opposed to talking about it in the meeting itself.
Mm-hmm.
But I took a different stance. So what I did was, like nerd style that I am, I went through all of the Grapevine articles. You can download Grapevine articles.
Yeah.
And so I went through every Grapevine article that mentioned medications or mentioned like physicians. There's probably like over the 75 years of AA or however long the Grapevine was around for, there's probably around 100 articles on
Yeah.
that. And I read
Out
through
of the thousands.
yeah, I read
Yeah.
through almost every single one of them. And
Okay.
there was a consistent theme on all of them. And it basically boiled down to practicing the principles in all of your affairs.
Mm-hmm.
And so it was practicing the principles when it came to prescription medications. And the principles on that were one of them was a tradition. AA has no opinion on outside issues. So medications became an outside issue. And then it was being rigorously honest with your provider about the nature of your condition.
Mm-hmm.
And then being honest with your with the doctor that was treating you as to what was going on with you. So it was basically like, how do I practice the principles in all my affairs when it came to medications?
Okay.
And so that goes back to the, being honest. And so what I tell my patients is, go ahead and let your physician know, or your surgeon know, or the anesthesiologist know, hey, I've had an issue with this in the past, right? And so I may have a higher tolerance, right? You may not be able to knock me out as quickly.
Yeah.
Or you may know, and then all my anesthesia friends are like, we know who the alcoholics are,
Yeah.
right? And like it takes forever to knock them out.
Yeah.
Right? They're like, you're just hitting them and you're hitting them and you're hitting them because they metabolize all the drugs so much faster than everyone else does. But it's just letting them know that, hey, I've got an issue with this, so that they're not prescribing you 120 Norcos like after a surgery. They're like, oh, like let's just do this, and then I tell them to put together a plan. What's your plan around that? What's the pain scale? How long are you going to do this for? And so that you're being more mindful of it and not just I just feel like taking one, right?
Yeah.
Well, is this part of the plan? Who's administering it? Who's controlling this? Who are you talking to about this with?
Yeah. Okay. So where does this specific addiction live in the brain?
Okay, so this goes back to the meso dopaminic pathway, the mesolimbic dopaminergic pathway, right? And it's the ventral accumbens and the nucleus accumbens. Uh, the ventral tegmental area and the nucleus accumbens, right? And like those, they're basically the reward system inside the brain. And then it is a loss of control in the prefrontal cortex when it comes to the overactive amygdala and the hyperactivity in that area. So it feels really good, and the very first time you take opiates, right, you hit that hedonic set point where you've got this high level of dopamine release, and all of a sudden you're chasing that release over and over and over again. And that pleasure, right, that you get from the dopamine, that splitting your system kind of like fades away, like the rest of the stuff that you would enjoy from life. You're not really
So it
getting the
kind of
same,
like dulls
all of
the
your senses,
ability,
right?
right?
Yeah. And so then you get a sense of dysregulation inside in regards to how you're managing your fears, how you're coping with your fears, and how you're going through all of that stuff.
Okay. Um, so can it develop? Can opioid use disorder develop out of like a prescription use, like appropriate prescription use?
Yeah, 100%, right? The same way. I mean, that's essentially how the opioid epidemic started up, right?
Right.
Is because we were having all of these things with higher and higher dosages of the opiates, especially for pain relief, that became emotional pain relief,
Yeah.
right? And so there was a guy, it was probably like my fourth or fifth year in recovery, who was a lawyer that had heard me lecture at the treatment facility I was working at, and he wanted to. They're doing a class action lawsuit against like the opioid companies,
Mm-hmm.
and I was like, it would be a really interesting thing to, or a perspective on the legal side of it, in that these people were essentially targeting people that had higher levels of trauma than it was people that were not traumatized. So this theory that the people that were abusing the opiates, right, didn't just fall into the category of like, oh, anyone can get addicted to the opiates, right? It was the people that had higher levels of trauma and pain inside their lives that were using it for the emotional side of it.
Have you seen that docu-series with Matthew Broderick?
Which ones did I see? I saw like a bunch of them, right? I saw Painkiller. I mean, I've
It
watched
was
them all.
Painkiller.
It was Painkiller. I
Yeah,
think I watched them all. They all blur together, right? I mean, they're all good.
it was amazing.
Yeah, they're all good. I mean, I think the one with Michael Keaton, was that the same one as him?
I don't know. I
I
don't
can't
think so.
remember.
Yeah.
I can't remember which one that was. But the whole point of this, right, is that you can get addicted from just the opiates that are coming into your system, right? So
Mm-hmm.
it's the same thing with like kratom, right? I'm getting
Yeah.
like the same receptors and the same dependency forms on that side of it too.
I just talked to somebody the other day that was saying that they got hooked on kratom on accident.
Yeah, I mean, I just had like two patients in the hospital said the exact same thing, and they were like, I didn't know how bad it was, and
Yeah.
I told you, right? Because one of them was a patient of mine in clinic, and I was like, they're like, I'm gonna just try this out, and then I was like, but it's not, it's the same thing,
Yeah.
and they're like, no, it's different. And I was like, no, it's the same thing, and there's a lot of deception around the marketing of all of those materials.
Oh yeah. Oh yeah. Well, this person, it was prescription Vyvanse, and then
Okay,
kratom, and this person had to detox off of that,
off the Vyvanse or off the kratom?
both at the same time. Because
Yeah, there's no detox for the Vyvanse, right? It's just sleepy time.
yeah, so that was the hard part was the kratom detox. This person couldn't sleep,
Yeah.
and then so it was just this wild 4 days of just being in pain and not being able to sleep.
Hmm.
Okay, so can OUD, right,
Opiate
opioid
use.
use disorder,
Yeah.
can it be cured?
What do you mean by cured?
Um, it just as okay. So when you look at cancer,
Yeah.
right, people like an addiction to cancer all the time because of the
Okay.
deadly nature of it, I believe,
Yeah.
and also the progressive nature of it, right? It's very deadly, very progressive.
Right.
The difference between addiction and cancer is you can see it. You can X-ray for it. You can point to where it is. You can remove it.
Right.
Um, but I think one of the major similarities is that it comes back all the time. So can it be cured in the sense of like once you are in remission of the disease,
Right. But
can
you
it
haven't
be
used it. You haven't used it in a
permanent?
while.
Yeah, well, once you've arrested that process, A, and B, you've had like arbitrarily a year, is it cured?
Yeah. So it's always available to you, right? I
Mm-hmm.
mean, like it's been what almost 11, 12 years now of like not drinking,
Mm-hmm.
right? The drink is still available to me. So like I don't ever think that I'm cured of my addiction. I think that I have had enough time away from it that it's not something that's on the forefront of my mind. It's not my go-to for handling like emotional pain anymore. And so I think that's what happens with people is that they stop using that as their go-to for handling emotional distress or like emotional pain, and the neural networks start to repair themselves, and lifestyle and connections, right, make it a lot easier to deal with life and a lot easier to handle life. And so we're not really looking at that anymore. um, Relapse risks decrease over time. So we've talked about this before. And there's studies out there that show that if you keep an Air Force pilot or Navy pilot sober for 5 years, they have a 95% chance of staying sober for the rest of their lives.
Mm-hmm.
And so all of the studies that were out there for doctors and for lawyers and for people that are in critical positions are based off of those studies.
Mm-hmm.
And so when I got monitored, it was monitored for 5 years, so that there's a higher chance of getting into recovery, learning how to self-regulate myself, and the healing is just a lifelong process. And there's a lot to be said for finding recovery as opposed to just being abstinent,
Yeah, for sure.
right? And because it's like, what do they call it? It's a dry drunk, right?
Mm-hmm.
I would much rather you be in recovery than and deal with the emotional stuff going on underneath it than not be in recovery.
Yeah, one of the things that I have found, at least for myself, in my experience around being a heroin addict, I can't go to the store and get heroin, right? There's like uh, a much more involved process in relapsing, right? Which can also be a deterrent in and of itself. Obviously, full relapse mode doesn't matter what you have to do, you're gonna do it, right? A
Yeah.
lot of people, at least. Um,
What do you mean by full relapse mode?
So when once using becomes a viable option, after
Okay.
you've had a month, a year, 5 years, 10 years, once using becomes a viable option, like for myself at least, there's levels to relapse mode, right? There's the initial like, okay, maybe I can get high again, right? There's
Right.
that thought. Then there's the like, fuck this. I just want to get high. There's
Yeah.
that, and then there's the full blown driving around
Yeah.
looking at homeless people like I wonder if he's strung out, like watching people.
So I've told you about the like not all thoughts are created equal,
Mm-hmm.
and that a thought supercharged by a feeling underneath it is more powerful than the thought itself.
Mm-hmm.
So I can have fleeting thoughts of, I want to have a drink, right? I mean, I still have those thoughts today. But the idea that I need to get a drink right now and it's a compulsion just is not there for me.
Guess who's here?
Megan.
Mr. Butterworth.
Oh, nice.
He's a regular.
He is a regular. Okay.
Okay, keep going.
Okay.
Okay. So yeah, there's levels to, I always say like full blown relapse mode, right?
Right.
Um, one of the things, at least for
Wait, so when you're in full blown relapse mode, right? My proposal is that full blown relapse mode is when the amygdala is at its most hyperactive.
yeah, you're in stage 5 of the escalation,
Yeah,
right?
you're in like that super
Unrelenting fear,
Yep, and
like
you just want
completely delusional paranoia.
whatever you want to do, whatever you can do to get out of that feeling because that feeling feels like death.
Yeah,
And so the theory is that if we can keep people out of that particular state, that the desire to go use or check out is just not there anymore.
yeah, yeah. I mean, I've told you that like I think that certain drugs tend to have like specific mannerisms of the addict. Like their
Mm-hmm.
tweakers act a certain way, heroin addicts act a certain way, Coke addicts act a certain way, alcoholics act a certain way. They all have like differentials in their mannerisms, um, like during the use and after use as well.
Right.
But specifically with opiate addiction, and we're talking about um, relapse and its availability and like the things that you would have to go to, like in Houston,
Mm-hmm.
you're not just gonna go out and find readily available opiates. Like at least in my experience, right? You got to go through like this adventure of probably shouldn't even call it an adventure. It's like a chain of events typically to find what it is. Whereas alcohol, I can go to the gas station right here,
And
and
pick it up. Yeah.
yeah, it's like right there, which is a in and of itself, like in early process of relapse, is a deterrent for a lot of people. At least it was for me. Um, so how does opioids rewire the brain?
Okay. So we've talked about this
Mm-hmm.
also, right? Is that the opiates bind to the mu receptor, and that mu receptor, when it gets fired, releases a huge amount of dopamine into the system, and that flood of dopamine reinforces the importance of that drug, right? So the more times you do it, the more reinforcement it gets over and over and over again. And the brain receptors, right, sort of get sensitive to that. And after a while, your endorphin levels start to plummet because you're no longer getting the endogenous form of that endorphin. You're getting it from an external source.
Mm-hmm.
And the motivation collapses without that drug. You're not getting the dopamine. The dependency sort of forms, right? And you're not getting that natural balance of things. And so it's chronic, and the changes last for months. And so what we're doing is we're trying to get the patient stabilized from that overuse on those receptors. But the healing is slow, and it takes time to reverse all of that stuff.
Yeah, the healing part is really slow. The thing that's most amazing to me. So I did my last treatment episode was 3 years, right? Like the
Right.
so it wasn't until 18 months where I felt normal again. I wasn't like happy. I wasn't able to like enjoy things. Food didn't taste as good as I thought it should or whatever. And then
Yeah.
around 18 months, I realized, woke up one day and I realized, like, oh wow, I'm kind of like back to normal, right? But one of the things that was most evident to me was my mood. It wasn't ever up and down, it was just continually flat for a long time.
What do you mean by that? Your mood was flat, right?
I was never like extremely happy. I
Okay.
was never even like really happy. I was never even just kind of happy or like extremely sad or kind of sad or just a little
So
sad.
you had like no manic episodes during that time?
Mm-mm.
No upswings?
Not really upswings, but I was also in like a lockdown facility.
That's true too, right? So I always tell patients when they're like, I don't know, like, I got diagnosed with bipolar, but like I was in treatment for like 6 months and like, didn't have any swings. And I was like, yeah, you were contained for 6 months, right?
Yeah.
Like, did you have anything to worry about? Any stress? Anything? They're like, no. Like, it was chill there. And I
Yeah.
really enjoyed it. And they're like, great. And they're like, yeah, but as soon as I came out, right? That very first day that I came out, right? It was
Mm-hmm.
like off to the races.
Yep.
And I'm like, yeah, because your fear was reactivated. So all of this stuff for me boils back down to fear and how fear gets processed inside of the body.
Mm-hmm.
Um, so I mean, I could see being in lockdown not having those upswings at all.
Yeah. I mean, it was really beneficial for me, right? I didn't really have these situations that I was exposing myself to
Uh
that
huh.
I could have like historically used as like a reason to relapse. I was in a very safe, contained place. I was fed, clothed, and like all of my basic needs were met. Um, but when we talk about like post-acute withdrawal syndrome
Mm-hmm.
and how long that can take, it's amazing to me like how long opiate withdrawal, post-acute withdrawal, that process takes.
Yeah. So I'm writing the chapter in the book right now about not getting things re-triggered.
Mm-hmm.
And so I'm thinking and like reflecting back this week on all the things that I did in my early sobriety to like make sure that I wasn't being triggered, right? And a big portion of that was sober living and being in safe spaces,
Yeah.
not living by myself, and like not taking on too much at work. Like work wouldn't let me go back to like full time for a
Mm-hmm.
good like 3 or 4 months after they're like, you're gonna do outpatient. You're gonna do like
Yeah.
nothing that was like critical. And I was like, I was resentful at first, but then I was like also grateful because I was like, oh, like this is kind of chill and stress free, right? I
Yeah.
don't have anything
I
like too
mean,
much to worry about.
did you come to that realization real time, or was it like in hindsight?
In hindsight,
Okay.
at the beginning, I was like super resentful about it because I was like, they don't want me coming back to work, right? They think I'm incompetent. They think I'm retarded.
Mm.
I was doing better at work afterwards. It was incredible how more present I was, how much more aware of things I was, and I was like, no wonder they thought I was dumb and an idiot, right? I was like, came into work every day like hungover.
Fuck. Okay, why is fentanyl more dangerous than just regular opiates?
I mean,
How do you, what is, okay, why is fentanyl more dangerous than other opiates?
it's the potency, right? So it's 1,000 or 100 times stronger than morphine, and it binds to the mu receptor a lot stronger
Mm-hmm.
than the other ones, and a tiny dose can be lethal.
Mm-hmm.
It also is small enough to cross the blood-brain barrier quickly. That's why they use it for medical procedures, right? It's a quick onset type of medication, and it suppresses breathing almost instantaneously.
Mm-hmm.
Problem with it right now is that it's in almost everything
Streetwise, yeah.
streetwise, and I will be shocked at some of the people that are coming in to detox, and they will tell me, they'll be like, "Oh yeah, like I'm withdrawing from meth," and I'm like, "Okay, tell me what your withdrawal symptoms are." They're like, "Body aches and pains and diarrhea," and I'm like,
Mm-hmm.
"You're probably not withdrawing from meth, right?"
Mm-hmm.
They're like, "No, that's like my meth," and I was like, "Well, what are your effects from your meth?" They're like, "Do you feel as euphorically high?" And they're like, "Yeah, I just thought it was a bad batch." And they're like, and then we test them, and they're positive for fentanyl.
Yeah.
You're like, where did that all come from?
Yeah, it's amazing to me the amount of exposure that the just random street drugs has to fentanyl nowadays.
Uh-huh.
When fentanyl really first hit the market, it started appearing in meth. At least from my experience, it started appearing in meth, and then we started seeing that they were pressing pills with it. It was in everything,
Yeah,
very
I know
quickly.
the press stuff is there. I just haven't seen it in like the marijuana, but people aren't buying like they're not buying from what I gather today, the marijuana that's being purchased are just they're exporting it from like stores in California.
Yeah. So I had recently been having a lot of conversations where I talked about people having exposure to fentanyl through marijuana, and I heard about it like on the news or like read stuff or seen clips or whatever. So I was like, you know what? If I keep saying this, I need to like really look at what's going on. And
Yeah.
so got on ChatGPT, had it like spider crawl the internet, like find me how many verifiable times people overdosed on fentanyl from smoking weed. And what it said was that it's extremely difficult to verify the stories and the sources
They
based
call
on
yeah.
just anecdote, right?
Yep.
Um,
Because no one's testing for it, right?
right,
No one's saying like, oh, like, you were you smoked some pot and you had to go to the hospital, right? Nobody's testing for fentanyl.
right.
For me to get a fentanyl test in the hospital, even though I'm doing this kind of work, like it took an arm and a leg, and so
Yeah.
most people don't even look for it. And so if you're not looking for it and it's not on a standard panel, you're never gonna know that it was there.
Yeah, and that's another crazy thing. So, look, ChatGPT said that there was one verifiable story
Okay,
that was like verifiable. This person smoked weed. It
right.
was laced with fentanyl, and they overdosed. The thing about it that I want people to hear and remember is that if you are buying drugs from the streets, if you're buying weed from the streets, no matter what it is, the the average drug dealer doesn't know where it's coming from.
Right.
It's coming from somewhere else. That person got it from somewhere else. The likelihood of it being cross contaminated is super high.
With something.
And
I mean, I've heard more stories of being cross contaminated with like PCP than
oh yeah,
anything else.
yeah, that's more intentional. I'm talking about
Yeah.
accidental cross contamination because stuff's okay. So here's a story.
Oh, you mean like it was just there and then like they.
They were packaged together coming across the border.
Okay, got it.
Um, when I was in, this was in 2018. 2018, I was getting super sick, and everybody called it botulism. And I was like, "What the fuck is botulism?" Right?
Uh,
And we would get like these. It's our burps smelled like rotten eggs, and we couldn't control our bowels. Like it was explosive.
your burps smelled like
Rotten
rotten
eggs.
eggs.
Painful. Stomach was in so much pain,
Okay.
and it was coming out of both ends, like explosively without warning.
And were you withdrawing, or
No,
did you
no,
really
no.
have botulism,
This is what happened. There was
or was it like cholera?
contamination. No, no, no. It was contamination from drugs being brought across the border in dead bodies. And so they were transporting drugs through with dead bodies, and it was getting cross contaminated from whatever the chemicals were in the body. And so a bunch of people on the streets ended up super sick with this stuff. I before I talked about this today, I made sure I made sure I looked it up.
Okay, what was it actually? Like, was it some type of bacteria that
Yeah,
you
it was a
had? Let's say
bacteria.
like salmonella or something like that
It was a bacteria and it said it like, yeah, this
from
is very
cadavers.
very common
So
that
if you're okay, got it. Okay,
that
okay,
drugs coming across the border in bodies
okay.
get contaminated with bacteria.
I always learn so much from you, right?
Yeah. Isn't that
Okay.
gross though? But the bottom line is the cross contamination around
Why
these drugs.
why in bodies? Like,
So this is what we were told on the streets. I didn't ask that,
okay,
right? But they don't search bodies the same way that they would search freight
yeah, because
out of
it's
respect for the
yeah,
dead.
got it. Okay.
And so they're doing everything and everything. They were
And like
pressing coke into plates.
yeah, but I mean, if it's no, when I'm thinking about sneaking stuff across the border, right? I'm thinking about like cocaine.
Yeah.
But so it was really interesting. Like, did you ever watch you watched Narcos, right?
No,
You
I
did?
haven't.
Oh, so good. Yeah, so good. It was interesting to see the progression from how much marijuana was like in terms of like bales of marijuana, right?
Right.
Like how big they were to actually make a profit, to then getting it down to, okay, well, instead of like this entire huge bale, right? All you need to do is like this little brick of cocaine, and it's the same amount, right?
Yeah.
Imagine how much less you have to do with
Oh
fentanyl
yeah.
to make the same amount, right?
Hmm.
And so it's like it's that much more potent and that much easier to transport.
Yeah. Yeah. Well, okay, so the bottom line around the cross contamination is we don't know where the stuff's coming from.
Right,
We don't know who's touching it.
right.
And the thing is, you see these videos of cops that pull someone over and they literally open the door and they overdose,
Mm,
right? There is minimal interaction with the drug, but that is all it takes. It could be in the air from them just smoking an hour ago or whatever.
right.
And just like uh, jarring the door open will release something into the air
Yeah,
and
like it
they're
feels like a plume
overdosing.
of smoke. Yeah.
Yeah.
Yep.
Yeah, and you can't see this. Like it's such a minuscule amount. And the bioavailability of this drug, it every possible way that your body can absorb it,
It
it
absorbs
will.
it.
Through the skin, mucous membranes, the stomach, every possible way.
Yeah.
And so it's an extremely dangerous situation around fentanyl.
Yeah.
So, can the brain fully recover from opioid use disorder?
I mean, that's what neuroplasticity is all about,
Hmm.
right? That's the beauty of neuroplasticity and how the receptors start to regenerate really slowly. The natural amounts of dopamine in your system start to come back. It may require months to get fully stable, but it is possible and it does take time. The most important thing that I like to stress is just to be gentle with yourself and like let the community and the fellowship take hold and allow for that healing to occur in the context of community, right? And there's certain things that can increase receptor sensitivity. Mindfulness for sure helps to rewire everything, but the main thing is just time and like getting emotionally balanced. I think that for me is the main reason why people relapse over and over and over again, is because they haven't addressed the underlying fear and the underlying trauma that exists
Oh yeah.
underneath all that.
Oh yeah. No, well, you have to be in that place of safety and stability in order to really address that stuff anyway. I think it always blows my mind when people talk about like doing trauma work in the first 28 days of treatment.
Yeah, no, we have we ever talked about this?
Yeah, with a bunch, you know.
Yeah,
It's
and I
like
was like, you can't. The analogy that I give is like you have to go build your operating room. You can't go do brain surgery right in a dumpster fire.
yeah.
And so like I need for you to go and build that operating room or that exam room, and that room for me is filled with your community.
Yeah.
So the stronger your community is to support you in that, like the better off it is. I mean, I did my trauma work during the pandemic, and that was not advisable at
Yeah.
all, right? Because like
Yeah.
just all the support that I had there before wasn't there, and
Yeah.
it was a mess.
Yeah. It,
Yeah.
it, 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 it always blows my
But
mind.
I don't. I think it's because like there's an added there's an added component that you can actually bill for, and I think that's why they do it in treatment,
I'm sure, dude.
right?
It's
Like it didn't make sense why they were doing EMDR that early.
oh yeah, well that's probably a professional service,
Yeah.
right? And so there's well anyway,
Okay.
it's I for somebody who's done drugs for a year plus, um, the ability to stabilize enough to get to the point where you can address the trauma without re-traumatizing,
Right.
and then here's the biggest problem: you're not committing to lower levels of care, and then you go back out there, you're re-traumatized, you're reactivated, your fears
Reactivate.
reactivated, your
Yep.
trauma's reactivated, and now
Yep.
you're out there spiraling with no oversight, with no accountability, with nothing,
Yeah.
becomes a very viable option very
I
quickly.
I really like the model of, go to treatment, do your PHP, your IOP, build your community for a year,
Hmm.
and then commit to, all right, like I've got a year of stability underneath my belt, right? Like let's go poking around and see what else is under there,
Yeah.
right? But after you've built enough of a connection with that, and the way that I equate that to is, I did my ACA work really early. Do you know what
Hmm.
ACA is?
Hmm.
Adult children. And there would be people that walked into the room for their first meeting. They would hear something for like, like half an hour, and they'd be
Yeah.
like, "Peace
Out of
out!"
here.
Like I'm done. Like not ready for this at all. And the
Yeah.
thing is, you'll know if you're ready, or you'll know if you're not ready. But this goes back to like the being numb part,
Yeah.
right? I was so numb, and it was all an intellectual process for me that it wasn't. It didn't reactivate me the way that other people were reactivated by it.
Yeah, that makes sense to me.
Yeah.
It does. But I think also the type of trauma kind of tends to. So different types of trauma are addressable at different parts of your recovery. Um,
So, wait, say that again. Different parts of your, yeah, definitely.
there are traumas that can probably easily be dealt with a couple months of clean time.
Yeah.
But there's also trauma that like you really need stability. You really need,
Yeah.
and the part of the brain healing around this. You said something to me that was eye opening one time. You told me that every time you have a new thought, a new pathway has been opened up. And when
Yeah.
I used to historically think about neuroplasticity, I had no clue what I was. I had no clue how to conceptualize it or like what even started this process of neuroplasticity or
Right.
neuro regeneration. Like, what is this? And you just said, yeah, a thought,
A
a
new
single
idea.
thought. Yeah,
Yeah. A new thought. Like I love the Inception's like one of my favorite movies,
yeah,
right? And it's the origin of an idea. Like at what point in your life did you have that first incepting thought? Right? And what happens with that thought is that it gets reinforced over and over and over again, and then an ego gets formed off of it, which is essentially the idea of inception, right? Like
yeah.
let's plant an idea, a simple idea, so deeply inside of it that it then takes root and it restructures like the formation of his persona,
Yeah.
right? That simple idea. I also like the idea that when you do your step work and you go down deep enough and you reframe a certain idea, that entire branch automatically reforms itself
Hmm.
because you changed the sponsoring idea from that.
Yeah. I mean, the way that a problem is framed and then the lens that you look at it through can completely dictate where you take that.
Yep.
And so as you do the work and as you get more stability, which is massively important around this stuff, like it cannot be emphasized enough how important the stability and the safety,
Yeah.
like the building of the safety barriers around you, how important that is. But when you can get down there and you can address this stuff, and so like when I looked at my sexual trauma, like therapeutically,
Mm-hmm.
it ended up being very different than what I thought it was going to be my whole life. I had avoided it, ran from it, covered it up, not talked, literally not talked about it.
Right, right, right.
And at the end, like by the end of like addressing it through therapy and like doing this work, was it was like very relieving to hear my therapist be like, "Dude, look, you're not using over this stuff," and it was like, okay,
Yeah.
like I'm
Yeah.
okay,
Yeah.
you know.
No, and which is awesome, right? Like
Mm-hmm.
you finally get to a point, but I think that's when the addiction gets released.
Yeah.
So there will be what my experience has been is that the core addiction gets let go of, right? But then these ancillary things start to pop up,
For
right?
sure.
Which are not going to kill me, but like kind of make my life unmanageable.
Well, I mean, I've said it, right? Like I can turn a candy bar into a problem.
Yep.
Well, I shouldn't say that. I know somebody right now that's turning Three Musketeers into a problem. Okay.
Well, I won't say who it is, but if you're listening, I've got my eyes on you.
Uh, oh no, they're listening.
Okay. That's so mean. That's
What
so mean.
what makes opioids uniquely reinforcing?
Okay, so it's the idea of it combines the pain relief with the euphoria of it, right? So if it didn't have the pain relief and it didn't have the euphoria side of it, right? I mean, it would just be like any other drug,
Okay.
right? With the euphoria side of it, but because it's got the pain relief, it engages the survival instinct pathway, right? And that condition, right, conditioned with the emotional relief, becomes a really powerful reinforcement,
Okay.
right? Because now you've gotten two particular pathways that you're addressing. And the body starts to think, oh, like this equals safety, right? And then this quiets down the amygdala. And this is what I need to feel safe. This is what I need for long-term survival, right? My body needs this.
Okay. Do you think that different drugs address multiple things as well? Let me ask you this way.
Different drugs.
Yeah, so part of meth addiction
Okay.
for a lot of people has a sexual component to it.
I think that it didn't address it. I think that the sexual side gets the sexual addiction gets paired with the meth addiction, and it's really difficult to separate the two of them,
Okay.
right? And I think what's so I've do you know how someone the arousal mechanism? Uh, so there's two sides to it, right? We learned this in med school. I thought it was always so funny that it's point and shoot,
Oh yeah.
right? And so in order to get an erection, you have to be in a parasympathetic state.
Mm-hmm.
You have to be like relaxed and calm and all of those things. But in order to ejaculate, you have to be in a sympathetic state, right? So that it's the differential
Oh wow.
between the parasympathetic and the sympathetic state.
Okay.
And so then this you're getting aroused, and once you hit this threshold
Oh
is
wow.
when you actually ejaculate, right? So imagine if you're on meth,
Yeah.
right? And your sympathetic tone, right, is not here, it's up here,
Yeah.
right? And so you're building up, building up, building up, building up, building up, trying to get to this point, right? To actually have the release.
Okay. So this is where like the mental component
The
of the sex.
mental,
Okay.
right? And so then it's it's basically like getting a dopamine release over and over and over again, trying to get to that point where you
Yeah.
actually have the ejaculation, right? So you've heard stories about people having sex for like
Hours.
hours,
Yeah.
and I was like, what? These are the stories I would hear at Lambda, right? I was like, you did what? And they were like, yeah, we would like you'd be on Viagra, but like Viagra wouldn't work, and so you get an injection into your, and I was like, what? And they're like, we would do that for like so that you could like have sex, and I was
Crazy.
like, and they're like, there would be no other way because
Yeah.
like in order to get an erection, you have to have the sympathetic tone or the
Mm-hmm.
parasympathetic tone, and so if you're in the parasympathetic tone, um, and I'm sorry, if you're so stimulated with a sympathetic tone that you can't get an erection, the only way that you can do that is with like severe vasodilation,
Mm-hmm.
right? And that's what like the Viagra and all of that stuff are.
Okay. Okay. Are all opioids equally addictive?
Uh, a, Equally addictive is like a really weird question. I think it would be like do they have different potencies to it, right?
Okay. Let me ask you like this. Um, is it just as likely that like a Vicodin addiction takes root as an oxy addiction?
I don't know which one's more. I don't know what I don't know of the two, right? Because I never prescribed them. I don't know which of the two is like stronger. I think
So oxy is much
It's not-
stronger. It's also like
wait,
a
but hydro like so I know Dilaudid is hydromorphone,
yeah, and
right? So that's more powerful than the oxycodone,
mm-hmm,
which is less powerful than the hydrocodone,
mm-hmm,
right? So you went hydrocodone, oxycodone, uh, hydromorphone, and then fentanyl,
mm-hmm.
right? And so of all those, right, like the dependency, I don't think anyone jumps straight to Fentanyl. I've never seen anyone jump straight to fentanyl.
I think we'll see it. I
You'll
think
start seeing it.
I think that as it becomes a more pervasive thing, um, I'll give you an example. I went from where I started straight into heroin within 3 weeks,
Where
and
you
then
started with straight into heroin in 3 weeks.
yeah, so I got exposure to oxys,
Okay.
and then within 3 weeks I was using heroin.
Was that because of cost?
No, it was because of availability,
Okay.
price and availability. But the thing was, by the time I was really like deep into my addiction, I knew people that went straight into heroin off of smoking weed. Um, and I think that as fentanyl becomes more prominent, that we will end up seeing people go straight for fentanyl in their early addiction.
And so the reason I'm hesitant about that is because of the respiratory depression that comes with it.
Yeah, but we're talking about the jump into your addiction. So the likelihood of
Oh,
somebody
okay.
abusing,
Yeah. So
I don't
because
think,
that very first time, right, you're not going to get you're not going to have the tolerance to it at all.
right?
And so what I'm saying is that you have to build up your tolerance to be able to go and use that as a viable substitute for it, right? You can't just jump from, like it's like having a glass of wine, right? And then going to like, all right, I'm having a glass of wine, and then going to like
Having a
Everclear,
glass of Everkilling.
right? Like it does, like there's a set progression to all of that. So I
Yeah.
don't know if you would jump directly from like
Smoking weed.
smoking weed to like doing fentanyl, right? I mean, there would be some other gateway opioid that you would like need to build up to get to that point.
I hope.
To build up enough of a tolerance to actually tolerate that. Don't get me wrong. I had this 18-year-old that came in and was on fentanyl,
Yeah.
right? And I was like, "What? Where are you getting this from?" And then she was like, "Oh, I've been doing this for a while." And I was like, "What?" Like, and it was just I think she started off with like maybe pills and like getting like legit pills, and then it just
Oh yeah.
this is what I have now.
You know, somebody said it yesterday. Who was it? Anyway, he was like, "Yeah, fentanyl's like a playing Russian roulette," and I was like, "Yeah, with 5 bullets instead of just one."
Yeah.
You know, it's just so dangerous.
No idea what you're gonna get, and especially like the stuff that's out there right now, like no clue, no
Yeah.
clue if that's gonna be it's gonna be like 50% of the tablet is fentanyl, or if it's like pure fentanyl. Like I heard some guys were like they weren't even doing crushed pills anymore. They were buying straight fentanyl.
hmm There was, we've talked about this, I think, but the chocolate chip cookie effect of pills, like, and when they're
Oh,
artificially crushing these
yeah,
pills,
yeah.
there is no like quality control,
Mm-hmm.
and so you can end up with way more than you think or absolutely nothing. And I know people
Yeah,
that have ended up with like pills where they're like, "Oh, this sucks."
yeah, that's
It's like,
not,
yeah,
yeah.
okay.
You got the bad one, or like
Mhm.
someone else got like the really potent one.
Mhm.
But what really matters, right, when we're talking about potency, is like how quickly does it enter the brain or across the blood-brain barrier. And so the faster it moves across the blood-brain barrier, the more reinforcing it is.
And is this because of the size of the molecule?
So the blood-brain barrier, yeah, is about how it can actually get
Yeah.
into that
Like
space.
it has to move across the barrier, and
Yeah,
so it like smaller like molecular structures have a much higher affinity for passing through it, right?
no, smaller ones.
That yeah, smaller.
Yeah,
Okay.
more likely to pass through the blood-brain
hmm
barrier. Yeah, and then synthetic opioids bind tighter to the mu receptor. Right.
Why?
It's based upon the pharmacology of it and then how the receptor is situated.
So is it so you remember the the how do you say COVID without saying COVID? The pandemic thing,
Okay.
how it was talking about the spike protein and how it fit perfectly into the receptor.
Okay. Yeah. So it's like so the receptor is like the key,
Okay.
right? And so then you've got the thing that comes into the key. Some of them are the perfect match for it, right?
Yeah.
And they fit in, and it's like really easy to turn the key, and it opens up completely, right? Some of them are like this old rusty key that you have, and it still fits into the lock, but you gotta jiggle the hell out of it, right, to
hmm
actually get it to open up. And that's what I would equate like the bigger molecules to.
Okay.
They fit, they turn it on, but they don't turn it on completely. So that's the difference between like a partial agonist and a full agonist.
Okay.
So we talk about like Suboxone's a partial agonist,
hmm
right? Whereas fentanyl is a full agonist. And so it turns it on more so than it would with this one. And then binding affinity is how tightly does it bind, right? So going back with the key analogy, I would say how how sticky is the key once you put it inside?
Okay.
How hard is it to pull the key back out?
Okay.
Right? Is the affinity to it?
So are people out there manipulating these chemicals to fit better?
Yes.
That's and so
So
that's why we're seeing. Okay, go
so
ahead.
we can talk. So I mean, the best example that I can give you is the benzodiazepines.
Mm-hmm.
Right. So as benzodiazepines, when they were first introduced, right, you had like Librium, right? Super long acting. They're like, oh, okay, like that one's pretty good. It works all right. Like, what else can we do to like make it more like potent, right? And so like Librium lasts for 12 to like 18 hours,
Okay.
right? And they're like, oh, like let's do diazepam, right? Diazepam lasts about 12 hours. Oh, let's do Ativan. Ativan lasts about 4 hours, right? Let's do Xanax. Xanax lasts about 2 hours, right? And you get this huge spike up and a spike back down. They even developed one. I can't remember what it was called, but the FDA wouldn't approve it to be released to the public because they were like, there's no reason for you to have this, right? But they still developed it. But
Yeah.
they were like, there's no reason. Nobody needs their anxiety alleviated this quickly, right? And there's just no reason to have it, but you could keep developing it, right? And there's always ways of like modifying a molecule for it to bind tighter or to bind looser or however, right?
Okay.
I had friends when I was in grad school. He was like, "That's all we do. We do this all day long." And I was like, "What?"
Really?
And he's like, "We tweak a molecule here, we tweak a molecule there, and see what the
Really?
effects of it are."
And how do they do that? Like, how do they manipulate the molecule structure?
Because it's like how it folds, right? Well, it's not the molecule, right? It's like the drug itself, or like does this particular drug bind to this one, right? So like the drug itself is a pretty big molecule.
Yeah.
So like let's change the hydrogen here to
Like an oxygen.
an OH compound, right? So it's a why am I blanking on this? An alcohol. Let's change from a hydrogen to an alcohol. And so then all of a sudden it has different properties to it. It
Mm-hmm.
different binding receptors. Oh, we didn't like that one. Let's try this one and see what the binding affinity to that particular receptor is.
Megan
But
just
that's
told
what.
on herself.
Oh.
She said all food is a problem right now.
I'm trying for him to be kind and compassionate.
No, I am.
Okay.
I didn't say her name. She did.
Um, but so going back, so the shorter the half life, right, the stronger the craving, because the shorter the half life, you get that spike, and it goes back down.
Okay.
Right, and you're looking for that spike again, and it
Mm-hmm.
goes back down, and so it's constantly chasing that particular thing.
Okay.
Long acting meds have less euphoria,
Makes sense.
right? So like Suboxone. I've never taken Suboxone before, right? But like I think the very first time you take it, there's a release to it, right? Like you get a dopamine release.
Unless you're using it as a detox medication.
You
No.
don't get anything from that.
Mm-mm. Because think about what
Interesting.
you're coming off of is so strong compared to it.
Yeah.
It doesn't even put a dent in what you're coming off of.
So I've been toying around with the idea of like in detox, like we've been doing like ultra rapid detoxes inside of the hospital because I only get 3 days,
Mm-hmm.
and I'm only doing 8 milligrams, 4 milligrams, and then 2 milligrams. And the idea was that because it was so long acting that it didn't really matter how many I gave you that first time. It was just enough to clear off the receptors that were there, and then you didn't need anything else. That I could just give you like 4 and 2, and it would just self taper itself over the next couple of days.
And how is it working out?
They're fine.
Yeah.
They don't come back in.
Yeah, the beauty of that specific drug is the like the different components of it, right? So we're talking about buprenorphine in conjunction with the what's the other drug in it?
Naloxone.
The naloxone.
Yeah.
So when I was first explained how this works, it made perfect sense. He was like, "Look, this is what's gonna happen. We're gonna introduce this drug into your system.
Okay.
The first thing that it's going to do is kick everything off the receptors, which is why if you do it too soon, you go into precipitated withdrawal.
Yep.
And then, so the first thing it does is kick everything off, and then it allows it to attach itself.
Yeah.
And so when I was trying to understand,
Wait, that he said that that's what the naloxone does.
no,
first?
that the naloxone kicks everything off.
No.
Okay, well, it made perfect sense
Yeah,
to me.
I mean, you could explain it that way,
Yeah.
right? But that.
So how does it
technically-
actually work?
So it's all the buprenorphine. The buprenorphine is the one that kicks it off because
Really?
it's got a high affinity.
So it just bullies its way in,
It bullies its way in.
and then the naloxone just stops you from being able to get high on it.
Inject it. So from my understanding, right, was that the naloxone isn't a factor when it's dissolved underneath the tongue. right? So that doesn't matter. The only reason they put the naloxone component into it was so that you wouldn't melt it down and then try to inject it.
Because of the how fast acting it is,
Yeah,
and then how it has to metabolize.
right. And so
Okay.
so that way you're not crushing down the buprenorphine and trying to inject that. Is why they added the naloxone component into it.
Okay, that makes sense.
Yeah, and so it's strictly a deterrent, not to abuse it that way.
So he basically got it right, but said the wrong
Yeah,
drug.
yeah.
Okay. So tolerance, dependence, and withdrawal.
Okay.
Tolerance, dependence, and withdrawal.
Yeah.
What are the differences?
So you first get a tolerance to it. So tolerant, so you can be tolerant but not dependent.
Mm-hmm.
And so you've built up enough, like you've been using the substance for long enough to start building up inside of your system.
Okay.
Dependency forms when you can't go without the medication, right? Like there's a physical like dependency on it. And then a withdrawal is when you're actually withdrawing from that particular thing.
Okay, I have a question. What I was always told was that the more opiates you used, you actually grew receptors. Is that true?
Now I think it's so which one do you want? Do you want the legit like what the
I
medical
want
literature?
them both because
Okay.
this is a thing that is talked about everywhere amongst opiate addicts. Is like
So
the reason why the tolerance happens is because you're growing more receptors and it's covering more, basically, yardage.
the dopamine receptors or the opioid
The
receptors?
opioid receptors.
Okay, I know about the dopamine receptors. I don't know about the opioid receptors. I think if anything, it's diminishing the amount that's in there.
Okay.
I have to look that up because I'm not positive. I know what happens with the dopamine. I know what the literature says about the dopamine side.
What about that then?
Is that you're getting more and more and more of it.
Okay.
Right? I'm sorry. You're getting less and less and less of it. It's like it's pulling away.
Okay.
Right? But I don't think that that's what's happening. I think that those receptors are still there. I think that the way that they're measuring whether the receptors are there or not is because they're blocked. And because they're blocked, you can't really see that. You assume that it's diminishing, right, in size, but they're still there. It's just that they're blocked by something else.
Okay. There's 7 people in the chat right now. If anybody else has ever heard this, I know Megan has, but
Okay.
that when you use opiates, you grow new receptors and you have to cover more, which is why your tolerance goes up. Who else has heard that?
Because of the you grow more.
Mhm.
I think it's because you're not releasing as much of the endorphins that you would normally get, or the mu receptor, right, isn't releasing as much as you would get beforehand, right? So you have to stimulate it even more.
Okay.
Um, yeah, I don't know. I have to look. I have to figure that out or look that up, right?
Yeah.
And I don't know the exact mechanisms by like, or the like. Does this receptor go up or does this? I don't know. I don't know all of the details of that.
Okay.
But if Megan can catch GPT, that would be great. We should
Okay.
get Megan in here like later on so that she can be the person that like looking stuff up while we're chatting.
Mr. Buttersworth said that there's less sensitivity to the receptors. Mr. Butterworth, can you chat GPT that?
There's less sensitivity to the receptors.
Mhm.
Okay, yeah, I could definitely see that. Right, and so that because whatever the receptor is doing, right, you need to stimulate it more in order to get the same effect.
Okay, somebody said that they had definitely heard that, and then Megan said that she thought that it made new pathways, right? So a lot of us hear this, like where the
Right.
more you use, the more you have to use because you're generating more pathways, you're generating more
No,
receptors.
and I think a lot of it has to do with the dopamine release of it, right? So like
Okay.
as you go along, like we talked about the hedonic set point, right? The very first time you use the
Yeah.
substance, you get the most dopamine you're ever going to get from it, right? And as you go along, it gets less and less and less and less and less, right? So you need a higher dose response, right? Or a different drug to get the same amount of dopamine release.
Okay.
And so it doesn't feel as good.
Okay, that makes sense. I
Right?
mean, it makes sense both ways,
Yeah, and I
like
think
when you
it's
think about it.
yeah. I mean, I could justify and rationalize both
Mhm.
ways, right? I don't know exactly. I mean, I'll look it up for the next time that we talk about this.
Okay. So why is opiate withdrawal so miserable?
I don't know, Matt. You tell me. Why is it so miserable?
Uh,
Your first. Tell me about your first experience, right? Because I have no experience. I can watch patients go through it,
yeah.
and it's interesting to see because what I experienced from that, because I've never been through opiate withdrawal before, right? What I experienced with them is that they will just lay in bed and they'll be like, they won't do anything,
So
right? They'll just like lay there.
yeah, somebody just asked if hip hop is dead. How is Wu Tang Forever?
But
That is a really good question, and it's an unfortunate situation that we have to answer it. Right, that hip hop is dead. Anyway,
I don't get it.
so
What was that?
I don't even know who this is. Said Contra. My first experience. So ChatGPT said the brain adapts to the overstimulation. Your brain doesn't like extremes. Uh, to offset the constant activation, it starts to downregulate. It
Okay.
reduces the number of opioid
Okay.
receptors.
Yes. Okay.
Yeah.
So definitely said that right.
Okay.
So, but you said the exact opposite, right? The very first
Yeah,
one
that's
was
what
that
we
they
all
make more.
hear.
Yeah.
Yeah, that's what we all hear.
Yeah. And so Mr. Butterworth,
Mm-hmm.
Butterworth was right.
Yeah.
Right. They become less sensitive to
Mm-hmm.
it.
My first experience withdrawing, it was really not that bad, right? And then my withdrawal experiences, a lot of them was in jail. And so once the mental part of it is gone,
Mm-hmm.
once I knew I couldn't get out of the cell, there is no drugs in the jail. There is no chance of me like getting this, which isn't always true. There is drugs in jail, but not in your initial stages of it, right? By the time you have access to it, you've already kicked. But without the mental part of it,
Mm-hmm.
kicking opiates is really not that bad, or it wasn't for me. It was really like on the streets when you are kicking that it gets really bad because you can go out there and get it.
Right.
And so there's like the mental side is much more powerful than the physical side, to me at least. That was my experience.
Okay. Well, so from a biological perspective,
Mm-hmm.
right? What happens is there's a surge in the noradrenaline, and it overloads the system. You start to get like the flu-like effects that start coming from it, right? The runny nose, the watery eyes, panic, fear, restlessness starts to dominate. You guys start to get the restless leg feelings that are coming up
Mm-hmm.
from the dopamine dysregulation. Your muscles ache, vomiting, diarrhea. The vomiting and the diarrhea start because there's mu receptors inside of the stomach and inside the gut, right?
Really?
So that's where you get the constipation from. So the constipation, the opiate is suppressing the ability for the intestines to like be modal, right?
Really?
So they're not moving stuff around. So you get all this like
Oh my
backlog going on,
gosh.
right? And that's from the fact that there's the mu receptors, right? I know it's safe to give Suboxone once the patient starts to have their stomach start moving again. That
Mm-hmm.
means enough of the fentanyl and enough of the opiates have gone out of the system to be able to then safely give them the Suboxone. So that's what we wait for.
The okay, where does it go once it detaches from the receptor?
You poop it out.
Okay.
Yeah, like it's not binding to that anymore,
Um,
or
that's
it's
so
or it's
interesting.
degraded, right? It's degraded or it's been metabolized, or it's not. It's your body's gone through and like it's metabolized enough of it off, so it's not there anymore.
Okay.
Um, and so then the dysregulated dopamine system kicks in. The amygdala gets hyperactive, and that's where the anxiety kicks in. And the brain, right, is just screaming for relief via use at that point, right? It's like, how do I get this? We give them medications at that point to like help them go through the withdrawal. So there's a couple of medications that we use, and we can talk about that in a little bit.
Okay.
Um,
Is opioid withdrawal dangerous?
it's not fatal, right? There's been no one's ever died of opiate withdrawal.
No
It's
one.
just, no one.
Okay.
Complications from opiate withdrawal, right? They may have had like a ruptured colon, right?
Okay.
Or like because they're having like
From the.
some of the spasms that are occurring, right? Or the explosive diarrhea that you get afterwards,
Mm-hmm.
right? They may have had like some other condition, like a cardiac issue or like CHF, and they died of that, but it wasn't directly through the opioid withdrawal itself.
Okay.
That's why the insurance companies will not cover that when you are doing that in a medical setting because it's not deadly, right?
Really?
There's no, it's not the ones that are deadly are
The benzos and
the
the
benzos and
alcohols.
the alcohol, right? And then if you're withdrawing from opiates, they're like, so sorry, suck it up, go home,
Wow.
right? There's nothing that's going on with that. I mean, there's a risk of dehydration. There's like electrolyte balances that come from that. The heart stress, like I said before, with the CHF for like patients that are there, seizures are uncommon, but like possible, and it's usually due to them using something else besides the opiate, right?
Mm-hmm.
Like a benzo and opiate combination, like that's really common.
Oh yeah.
So when I'll see like, it's really interesting because they're not drinking when they're taking opiates.
No.
Why not? Because
They don't
I
inter.
never see that.
Those drugs don't interact well, and there's like a. So from my experience, and like
Why don't they interact well?
they don't feel good. They make you sick. But
Okay.
also, there's like a. I don't know if this is truth or not, but like there's a higher likelihood of overdosing because of the how thin your blood is.
A higher likelihood of overdosing because of how thin your blood
Wait,
is.
I've been separated from this for so long. There's some kind of belief that opiate addicts have around if you drink, there's a higher likelihood of overdosing. I just don't remember what the exact cause is. But it has something to do with like alcohol in the blood makes it much more likely for you to overdose.
Interesting. I don't know why that would be, right? My first is it injecting?
Any
I mean, it could lead to like an easier chance of you having respiratory depression because if you're drunk, right, you're kind of like passed out, and so then the heroin on top of that leads to a likelihood, a higher likelihood of you having respiratory depression.
Also, I'm because of it suppresses your CNS. That's
Yeah,
what Mr. Buttersworth said.
yeah, and so I mean, it's just like that. That's what I was just talking about.
Hmm.
Yeah.
Also, I never had that because I'm allergic.
Hey,
Like
are we in real time? That
hmm
was a really quick answer.
yeah.
So
We're
we're
like I think we have like a 6 second delay,
oh
just
that's not,
late
okay,
latency, maybe less than that even.
okay,
But I'm biologically allergic, not the
yeah.
alcoholic allergy. I'm like really allergic to alcohol, so I never had the desire to drink while I was using opiates. I actually probably used opiates more readily because of my
Yeah.
allergy.
So on the withdrawal side, right, there's a higher risk of suicide.
Oh yeah.
Medical monitoring is advisable for like comfort and health protection, but not 100% necessary.
Yeah. I think a very small percentage of opiate detoxing is happening in a medical setting. A lot of it is happening on the streets. A lot of it is happening in jails. A lot of it is happening in people's rooms because of their lack of access to it or whatever. Most people are not going to the hospital to detox from heroin.
No, because they won't admit you.
Yeah. Well, then there's that
They
too.
won't take you, right?
Yeah.
They'll be like, oh, we're so sorry, right? Or like that's why they call the Heroes program. So in Houston, there's the Heroes program,
The phone
which
call.
what do you mean? Oh, you've had experience with it?
No, well, so there's something. It's called the Angel Line, I think, in
Okay.
California. You're talking about the overdose prevention line.
No, so in Houston, there's a program called Heroes. So if somebody shows up inside of the hospital for, with heroin overdose or fentanyl overdose or some type of use, they'll call the Heroes program and they'll attempt to set them up with Matt,
Oh,
and they'll put them on like Matt if they stick around for that long.
is it? Did you find out through your friend? How'd you
Mm,
find out about this?
like way back, like when it first started. Like
Okay.
I just started my fellowship, and they've been talking about it, but they've been around for like probably 6 or 7 years now.
Okay.
Yeah, and it's out of UT, the UT health system. It's
They're
government funded.
doing
Yeah.
amazing stuff. Have you heard about? Well, okay. Um, so why do people relapse after detox? Which is so, and can the withdrawal be shortened?
Okay. So I mean, like why they're
I
withdrawing?
know.
Why are they withdrawing, or why are they relapsing after detox?
So it sounds really weird to say this now, right?
Right.
But like, um, now when I look at the battle of detox, I'm like, why would anybody relapse like right after they went through all this? Why wouldn't they just go use during detox?
Yeah.
Um, but
How long do you think people stay sober after they go through detox?
on average,
Yeah, just detox.
on average,
Yeah.
um, if I had to like quantify every single person, maybe a day.
That's for opiates, right?
Hmm.
Yeah, for alcohol, it's like I think I give them like about 2 months or so for most like alcoholics before
Yeah,
they
it
relapse
just
and start drinking
if
again.
there's no like plan for recovery, there is no point of not using.
Yeah,
If there is no like intention around not, most people are detoxing because of access. It isn't. It
Yes,
isn't like
yes.
a. I'm gonna It's so uncomfortable. Nobody's like just choosing to detox.
That was Dr. Leeds' favorite question in the detox thing, right? He's like, why are you here? They're like, oh, I'm trying to get better, right? I want to change my life. It's time. Like I need to get recovered. And he's like, come on, why are you really here?
Yeah.
Right? He would ask that question like three times, and he'd ask that question three times because they would always give you like some bullshit answer the first like two times. I'm like, oh, I'm trying to change my life, and he's like, come on, it's like Tuesday at midnight, and you're coming into detox. Like, why? And he's like, oh, my old lady kicked me out, or like whatever, right?
Yeah.
And it's usually like some type of consequence that came up that was like, okay, I'm here now.
Yeah. It's like a preventative thing, right? A lot of. So my experience was with the homeless demographic, and it is always an access problem, right? Unless there's like an intention to get clean. From my experience, there is no reason to detox
Right,
other
unless
than
yeah,
access problems.
I could not get it.
Mm-hmm.
Right, yeah, I've seen that a bunch too, and that's just or they need a couple days away from whatever's going on or whatever consequences are happening at
Okay,
that moment.
you know what? I lied. I knew people that would detox to lower their tolerance.
Oh, interesting.
Yeah, where they like get up to like just a dumb using a dumb amount. And they're like, you know what? This is so stupid. I should just detox and lower my tolerance, and they would do that.
How long would they have to go to before that would actually
Not
happen?
long, not long. Especially if you're like using that much.
Okay.
Once you detox, you've lowered your tolerance a considerable amount.
Hmm. That's so interesting.
Mm-hmm.
But that see that you wouldn't learn that in a book, right? You
No.
would only learn that from like being around it and then actually talking to someone that was willing to tell you the truth about like what really happens during their drug use. That's why I love talking to like I loved my time at Lambda and talking to like all the guys that were doing meth, right? Like I learned so much about meth through all of that. I'm learning a ton about heroin, right? Um, what other cultures are there, right? Like those are the three main ones, right? And cocaine culture and alcohol culture kind of mixed together. So I'm not really
Yeah, I mean, there's definitely a cocaine culture though,
of
and
just
there's different types of
straight cocaine.
yeah, cocaine culture and then crack culture. Those
Crack
are
culture, yeah,
yeah,
there's
those are
definitely crack culture.
and and there's a PCP culture as well.
Okay, we don't get those into the hospital at all.
Oh no, no,
Yeah,
no, no.
like when you're like, I just feel like when you're that far down the road, like in PCP land, like
What? Come on, I
I've
was
never,
using PCP.
I've never seen anyone come into treatment for PCP.
Let me think.
I take that back. In my 6 years, maybe two people
Okay.
where came in for PCP use disorder, right?
Yeah.
And I think the reason why I think they end up like a little bit psychotic, right? And they end up going to a psych facility versus a behavioral health facility
Yeah, that's
because
very,
the
very
behavioral
possible.
health facilities can't handle like the level of psychosis that may occur after the use.
So also the symptoms of PCP use are very psychotic.
Yeah,
You know, there's
yeah.
I robbed a bank on PCP.
Oh, that's the time that you were doing that.
Yeah,
Okay.
and thought it was just a bet. I can't even go into this bank without a mask on. You know, it was like
Wait,
very
what?
yeah, because it was in December of 2020. You couldn't go anywhere without a mask on, and so I was like, oh, this is the perfect time. Like it just makes so much sense to me right now.
That's so funny.
Yeah,
I mean, that makes sense, right? Like
it
everyone had to
made
wear a
sense to
mask.
me. Yeah, I was
Yeah.
like, oh, they're asking for it, right? Like so
That's so funny.
so can opiate withdrawal that time period? Let's call it 72 hours. Can that be shortened?
Uh, I can help shorten a lot of the symptoms that come up, but the withdrawal is going to be the withdrawal. Like
So can you
you're gonna get.
shorten the symptoms of the withdrawal, or can you like nullify them basically?
So I have to wait until long enough time has passed for the opiates to come off the receptors before I can give you the Suboxone.
Which is crazy because that's like the worst of it is done by the time you
You think
can.
so?
Yeah, I think so.
The worst of it's done.
I think so.
So then why do we even take it?
It's a mental thing for sure. The thing
Okay.
about it is like if your brain, if those
If
pathways have been reinforced enough.
if you know that you're gonna get relief soon, then
Mm-hmm.
it's like okay, I can tolerate it for this long, But in reality, then you could have just like tolerated it for a little bit longer.
I mean, I tell you, like one of my regrets around getting sober this time was not taking your advice and just getting off the Suboxone. That decision to continue, I don't regret it, but I wish I didn't make it.
I, we'll get into that, right? Because we'll talk about Suboxone in a little bit.
Hmm.
But like, I think there's a role for that, right? And there's a role for that in everything.
I do too.
Yeah.
I didn't need it.
Okay.
I think that as a maintenance drug for people with opioid use disorder and the mitigating of the chances of their relapsing,
Okay.
very very key piece of it's a key tool for preventing that for a lot of people.
Yes.
But the problem that I see and the problem that I had was how hard it is to come off of it once you are
Yes. Yes.
dependent on it,
Yes. Yes.
because it doesn't matter how determined or disciplined you are,
Yeah. So
without some kind of medical oversight, without a doctor that's will. So I
I
told
mean,
you,
I've had patients that have been on it for like since I started my practice, right? They came in on it and like they've not been able to get down past 2 milligrams.
it's
So
one of the scariest withdrawals
yeah, so
that
the
I've ever
two,
experienced.
so I've told you this before. The 2 milligram mark is where the true opioid addiction lies.
Hmm.
Between like m- my idea is between 24 and 2 milligrams, you're not using the Suboxone for your opiate use disorder. You're using it for mood stabilization.
Push it towards you.
You're using it for mood stabilization,
Yeah.
right? And so the idea is that I'm okay with you using it for mood stabilization, but if you're using it for mood stabilization, why would I just put you on a mood stabilizer?
Yeah, it's so this is the scary part about the continuation of the use of that medicine with specifically with opiate abusers,
Okay.
because it continues the same mental addiction and process as if you were slamming heroin. The self-dosing, the continual use, it
Yeah.
it even I think it crosses a line somewhere down the line, right? Like you might be really using it as a tool for relapse prevention, for craving, for like a craving dampener. But for me, I crossed the line into using it as a tool and then dependency and then almost abuse of it.
So I think that it's most effective when you're using it as a way to stop the constant searching and seeking process that goes on of looking for your drug.
Okay, but the problem is, this was my problem. I got 90 24 milligram strips a month. 90.
90.
98 milligram strips
Okay.
a month.
Okay.
The problem was,
How quickly were you out of them?
no, it wasn't that.
Okay.
My problem was somewhere about a week before I needed to refill it, I would go to CVS, and the CVS that I was using, they were like, "Oh, you're gonna have to wait. We have to order it." And in my head, I start panicking. It's like, "Oh my gosh, am I gonna like not be able to get this?"
You said a week before though.
Yeah. But in my head, it's like, okay, is it going to come on time? Like, what is it?
So
And
you were in
it's
that
gotten
like fire.
close. It's gotten close. And so
Yeah.
it's still seeking, it's still
I
panicking.
I will get more calls in clinic when someone has run out of their Suboxone and they didn't make their appointment, and then I'll just get call after call
Oh,
after
yeah.
call after call after call, and
They're
I'm just be like,
panicking.
yeah, and I'll be like, what, like, you missed your appointment. Like, what do you want me to do? Right?
Yeah.
They're like, can you just send it in right now? And I was like, yes, I'll send
Yeah.
it in right now, but like, you missed your appointment,
Okay.
right? There's
I'm
a
going to,
reason why we have appointments.
I'm going to tell you this. The likelihood of that person going to the streets to find Suboxone skyrockets if they cannot get their prescription.
The
It is,
likelihood of them, well, if you're going to go to the street to get Suboxone, why wouldn't you just go to the street to get,
that's the other part of it, right? Like,
right,
you have to be extremely dedicated to not relapsing
right?
if you're
So I
if you're
usually send, so what happens in clinic, right? What I do in clinic is I usually give them like a buffer of like 4 days, right? So like we give them enough so that there's a 4 day buffer, because you can always get your prescription filled early, right? By 4 days, 3 or 4 days.
okay.
So what I do is they'll come in and like let's say they came in January 1st, right? Their next appointment I would schedule it for January 27th,
Okay.
so that there's always a 3 day or 4 day buffer in when they're going to get their next medication,
Okay. Yeah,
right? And then sometimes I'll send in a little bit extra so that they have like a few days.
it's such a slippery slope.
Yeah.
It really is.
But then there's also like it's really interesting because I know the pharmacies in town that guarantee to have it in stock,
Yeah.
right? So there's certain pharmacies that will, if I send it out to like, you know, to the Woodlands, the CVS in the Woodlands, right? They're not gonna have it.
Mm-hmm.
But if I send it to the CVS in Montrose, they will
For
definitely
sure.
have it, right? They'll have plenty in stock, and they'll have like they will never be out of it,
Yeah. So I'm in Friendswood,
right?
right? And so it was. They
So
never
so
actually had it on in stock.
yeah,
They had
so
to
that
order
I
it.
wouldn't, and so I the patients that I have that are on that, I'm like, you pick a pharmacy, right, that we know that we can get it at, and then you make sure that it's there,
Yeah.
right? That becomes your responsibility, right? To like make sure, like, hey, how often do you guys get this stocked? How often do you like do this? Because like, I can't. There were some patients where they would call and I'd send it in, and they're like, they don't have it there, and then I'd be
Yeah.
like okay, and then I would send it in again, and they're like, they don't have it there either, and I was like, well, this is the third place I've sent it to,
But
right? Like,
but do you see how this could lend towards addict behavior
yeah, no, I wait, like,
for the patient?
yeah,
Right. They are now in like
in like
uh,
panic mode,
yeah, and
yeah,
where they are
yeah,
seeking,
yep.
right? And then it like I say all the time.
But it's hard for a provider to know whether or not they are misusing it or are actually like legitimately out,
I know, right? That's
right? Like
the
I can't tell. And so the thing is, I'll give a lot of grace those like the first time I'll just be like, okay, but there'll be a mental note to be like,
yeah,
wait a minute, right? Because I mean, in my early practice, I was such an idiot, right? Like I was just like, I'd be like, oh, okay, what, you lost it again? Like it's all right, like we'll finagle it around, right? Because I was like, I was trying to do right by the patient, and I was trying to like make sure, but then some of them would just take advantage of that. I was just
yeah,
like, now it's like a hard line of like, I'm so sorry,
yeah.
and I'm not the one that picks up the phone anymore.
So my question is, like, why is Sublocade not offered like off the bat?
It's cost, right? It's pure cost and like the difficulty in getting it prior approved.
Really?
Yeah, and so like we went through this process with the Vivitrol
I don't know
shot.
why I said really. I experienced that. I had to pay
Yeah,
for it out of pocket.
yeah, and so like getting the because it comes through a specialty pharmacy
Yeah.
is the only place where you can get it. And that specialty pharmacy has to like send it over to the doctor.
Mm-hmm.
I think it's like it may be refrigerated, it may not be refrigerated. Then you've got a certain window to like give it to you,
Mm-hmm.
right? Then after I've given you the shot and you certify that I've given you the shot, I have to then send in for the refill to the place again, right? To say, all right, send the next one in. And they'll go through the insurance process, right? Of like maybe they'll send it in, maybe they won't send it in, right? And then will it come in the mail? Well, will it not come in the mail?
Yeah.
Then it comes to the thing, and then I'm like, okay, like, hey, your shot's available. Come in and take your shot. Well, if you miss your appointment, right? Then I'm like, well, I still have your shot here.
Yeah.
And
You
so it's
know,
just it's a pain in the ass, right? Then and
mm-hmm.
it legitimately is. And I don't know if I don't have enough experience with Sublocade because, like I said before, I'm using the Suboxone as a mood stabilizer. And
Mm-hmm.
so, are you getting the same mood stabilization with the Sublocade if it's constantly in your system? Are you getting a dopamine release from it? And my proposal to that is no.
Yeah, I would agree. But that was just my experience that I didn't. But I keep hearing from a lot of people that they do.
That they get a dopamine release from
Mm-hmm.
it, but it's a steady stream, right? Like the idea is that you're getting a set amount from this like this gel matrix that's there,
I have a
that's sitting
friend.
inside of your like underneath your skin, and that's how you're getting a constant release every
Oh,
once
you're
in a while.
talking about from the Sublocade.
Yeah,
There is no. So my experience was I got one shot, never felt any difference ever. Got one shot, no withdrawal symptoms, nothing.
but that's from you said that you're getting the starting dose, right?
Yeah,
And that's the only time you ever got it.
one shot.
Yeah, I told we had the person come in, and I was like, this is amazing. It would be really good for people at the 2 milligrams wanting to come
Mm-hmm.
off of it, right? And that's what I would use it for. I wouldn't use it for maintenance
Yeah, I think that the self dosing part is dangerous.
of the Suboxone
Mm-hmm.
itself. Yeah, 100%, right? But that's why. So I have very few patients in clinic that I give Suboxone to. I would probably say of my 200 patients in clinic, I have I want to say 8 to 10 people on Suboxone. Like that's not something that I do.
Yeah.
It's not like my go-to, right? And it's like I have to know that you are being followed by a therapist or like you've got some type of community support.
Yeah.
And so I used to take all the patients that came from the treatment facility that I worked at, and I was like, anyone that was on Suboxone, they came because they were sending me all their patients. What I quickly found out was that it was a debacle, right? Not a single person that I started on Suboxone from treatment, right? What were they using it in the manner in which it was supposed to be used?
Okay. Yeah. I. I.
Yeah,
I
and of that, so I had one, two, three. I think I had like 6 or 7 patients from the treatment facility come in that were specifically coming in for the Suboxone, and none of them used it, or like they were all very quickly within a month, right? It would just degrade to, I need my Suboxone, and I'm like, you're using, like I know you're using, like I cannot refill it until you go back to treatment.
yeah. It's. You can build a house with a hammer. You can beat someone's head in with it.
Right,
It's one of those things of like, how are you going to use this tool?
right,
What is your level of dedication to your recovery?
and I think that it works out really well with Miss Dorothy. You see, met Miss
Mm-hmm.
Dorothy, right?
Mm-hmm.
And so she works for a state-funded Suboxone clinic, and they have such tight control or such tight like
Yeah.
parameters around it that
But that isn't normal either.
that's not normal, right? Because a lot of physicians are prescribing it out without the
Treatment
recovery, the
part
treatment
of it.
side of
Yeah.
it, right?
It's
And
funny
so
because
I
it's
like her model.
MAT.
Yeah.
There is no T, right? There is
Yeah.
no treatment. There is no therapy.
Well, so the treatment is the medication, right? Medication assisted treatment.
Yeah.
Yeah. Mm. So we didn't finish talking about all of the drugs that we use, right? So Suboxone's not the only one.
Yeah.
The other one that's a go.
And we're talking about opioid withdrawal.
Opiate withdrawal, right?
Okay.
The other go-to is clonidine.
Yeah.
You ever been on clonidine before?
Yeah.
And so what clonidine does is it's an alpha blocker, and so it reduces the adrenaline that's like going up, and so it causes your blood pressure to go down, your heart rate to go down, and for you to feel really really calm.
Yeah. So it is a blood pressure medication, right?
Technically, yeah.
Okay.
That's what it's classically used for. But what happens is what they found out is that if you block the adrenergic turn, the adrenaline tone that's going up, then you can like stave off some of the withdrawal symptoms. And so
Yeah,
back
well-
in the day before there was Suboxone, they would use clonidine.
Yeah. So this is what I'm talking about around the mental side of withdrawal is much more of a driver for someone to quit than the physical side of it. To quit their withdrawal.
Okay.
Yeah, so the mental part of the withdrawal is a much more powerful driver than the physical side to pick up.
Okay. Interesting. Okay. No, I can see that. So there's a couple of other drugs that are like new on the market. The lefexidine. I think I'm pronouncing that right.
Lofexidine.
Yeah, and it's the same thing as clonidine, but it's a stronger, more potent version of it, and that's also used to stop the adrenergic response going up. The other thing that we do in the hospital is we give nutrition, hydration, and all of those things, and it just basically helps to allow the people to relax.
Mm-hmm.
I don't give benzos out when you're withdrawing from opiates, right?
That was one of the things that I noticed about when I detoxed with you was there was no benzos.
Yeah, no, because you're getting the long acting pheno.
Well, which is also why I called my drug dealer to bring me Xanax.
Because you're not going to give me Adderall. I mean, you're not going to give me Xanax or
No, Valium.
Valium.
Yeah.
That's what you wanted. You wanted Valium.
Well, because every time I've had that experience of detoxing in a controlled setting, there was Valium like on the platter, on the way in. You know, it was like I was
Yeah.
like, wait, what? Oh wait, I can get a visit.
I can't believe like we're sitting here now from all of that.
I know.
Yeah. So yeah, I mean the whole point is how do I withdraw you safely? Which I mean you're not going to die from it, right? But like try to keep you comfortable so that you're actually open to going to treatment. And the really crazy thing is that as soon as you are done with the withdrawal side, the I guess the willingness to go to treatment kind of goes out the window.
Oh yeah.
Yeah, like in that, like you are like that first 2 days when you're withdrawing and you're miserable, you're like, oh, I'm gonna go to treatment. I'm gonna change my life, Dr. Shaw. It's gonna be amazing. And I'm like, where are you gonna go to? That's why I try to lock you in
Yeah.
on those like first 2 days and like get you to commit on those first 2 days.
Yeah. The emotional part of opioid withdrawal is really powerful too
Mm-hmm.
for a lot of people.
Describe that for me.
Uh, so something about that drug, like I've done a lot, I've done basically everything that's available on the streets, but when you detox from opiates, like you get a rush of emotions that have just been like it's like the floodgates open from like all of this shit that's been happening, and
Okay.
it all hits you like a freight train. And now all of a sudden, like you regret that lie, or you regret that, or you regret this, or like
Interesting.
yeah, and it's like just all waiting there for you to
Your
like
mind's like racing about those
mm-hmm.
things. Like the ideal time to do a fourth step.
Yeah, for sure. Dude,
Mm.
if you could get somebody to, like do one, two, three, and four in that like detail, dude,
And
it would be amazing. Probably the most
most
honest,
cathartic thing
brutal,
ever.
yeah, just the most honest and brutal four step you'll
Well,
ever hear.
we're opening up a center, right? So
Mm-hmm.
we should do a little
Experiment,
experiment
yeah.
and see how effective that is. To be like, hey, look, we're offering you this track, right? It's the non Suboxone, non medication treatment route, right? But what we're gonna offer you is starting on day one, right? Is we will take you through and do your entire fourth and fifth step, right? By the time you're done with treatment.
Yeah. Or we could do this. We could say it before you dose, you have to do one, two, three, and four. Okay. So how does dopamine fit in as far as like so opioids are really good at hijacking the reward system.
Uh-huh.
So how does dopamine fit into this whole process?
Well, so the idea is that dopamine is the motivation signal, right? It's
Mm-hmm.
not actually the thing that you get for pleasure, it's the thing that's driving you. I consider it the searching and seeking hormone or the neurotransmitter. And so it's not about the actual pleasure that you derive from it, it's the motivation to go do something.
Mm.
And so opioids trigger a huge release for this. And so when the brain starts getting that dopamine release, it says to itself, hey, this is probably pretty important. I should probably prioritize getting this particular substance. The natural joy fades away, dopamine baselines start to drop, pleasure circuits are numbed, and the craving for that particular substance starts to go up because your brain now thinks that this is what the most important thing for survival is.
Oh yeah.
Um, and it's crazy how quickly that process starts, right? Or how quickly that all goes together.
Keep going.
Hmm?
Keep going.
System to heal. What happened?
The camera has been on for way too long.
Okay. How long has it been on for? Did it overheat?
Few hours. But
You have a second camera.
yes, we do.
So when did it went out?
Yeah, it just shut off.
Did it overheat?
I don't know.
Can they hear us?
Yeah.
Now they can see us.
Yeah.
That's awesome that you got two. Better?
Yeah.
Back on?
Okay, Mr. Butterworth said it. It's only been out for a few minutes. But it won't come back. I don't know why.
Oh, it changed colors.
Did it?
Oh, that changed colors.
The
The camera did.
okay.
So you want to? Okay, so let's talk about after you got done with treatment, right? How long did it take for you to start getting your feelings back?
Me?
Yeah.
So
I mean,
got
how
'em-
long were you numb for?
I mean, I got them back like up front, like immediately, and then it kind of like waned again,
Okay.
and then yeah, it was probably like I don't know, a month and a half.
Okay. Yeah, and so that's completely normal, right? As your dopamine stores start to reset, it takes time and like structure, right? It requires a steady state of abstinence, balanced to help repair routines that are really helpful in terms of like a systematic, we're going to get up at this time every day. We're going to do this every day. We're going to do this every day. Sleep is crucial. Nutrition for the proper neurotransmitters coming back. Mindfulness rewires habits. Controlling stress and keeping out of the fight or flight response. And then eventually the joy and the euphoria start to come back, which is great, right? The mood stabilizes and you're less likely to go back and use. You're still working on it, aren't you?
I am. I don't know why it won't turn that camera back on.
Do you have to reset everything?
I hope not. I hope not. I don't think so. I just gotta. Okay, that turned on.
Ooh, sorry.
Oh, it won't let me turn. It won't let me switch the camera for some reason. Okay, camera. I would have to reset the.
Reset the session.
Yeah.
I was going to kick everyone off.
Mm, I don't know. Let me try this. There we go.
Okay, great.
Okay, we're back. Okay, so how does trauma increase addiction risk?
Okay. So, I mean, chronic stress alters the amygdala. And so some of the studies have shown different things in terms of how it changes the fear circuits and how it elevates cortisol. So, cortisol is the fight or flight neurohormone. And opiates, right, quiet down this hypervigilance. And we've mistaken the relief that we're getting from the pain and the hyperactivity and the high stress states as something for healing, right? The emotional pain temporarily numbs out, all
Bring
of those
just
things.
just bring it closer to you because you keep backing up.
Yes, I'm aware of that. I also think I'm backing up because it's not high enough, or it's I don't know. I don't know what the deal is. I'm working on it.
Okay.
Um, yeah. So the addiction loop. I'm sorry. So the brain encodes opiates as feeling safe and having safety, and so that addiction reinforces that particular trauma loop. And then the brain starts to think, hey, I actually need this particular thing to feel better or to feel normal. And so that system gets hijacked.
Go ahead.
Okay. And so there are certain brain areas that change due to the trauma. And so studies out there show that they're like half and half. Some of the studies show that the amygdala gets smaller in size and it shrinks down due to trauma and high cortisol levels, or some of them show that it actually increases in size. And so there's like, it's like half and half. So not really clear what happens with that, but they definitely know that the hippocampus shrinks. And that's what cortisol does to the hippocampus. It kind of atrophies all the neurons that are around there, and that then causes a weakening of the prefrontal cortex, where all the emotional memory is encoded, and so the logical control then gets reduced, and then triggers persist right unconsciously. So if someone gets triggered by something, it goes and goes and goes because there's nothing in the prefrontal cortex to actually dampen it down or shut it down.
So when you described the different pathways to me the first time, okay, I don't know if this is just known, like the short pathways, the long pathways, and like the relay basically that happens. Like I
Right.
didn't understand like that the short pathway
Right.
is the quicker pathway, and it also like has like the more negative reactions attached to it. And so
Yeah.
like the positive ones, which and then I remember what I asked you. I was like, why in life is the good things always harder, and all the shit that fucks you up is like
Is
way
it easy?
easier? Yeah.
Yeah. No, and I think that it's us talking and like getting to like for you to get to understand the model like has like I mean you're a really well-read person and like highly intelligent, right? For you not to
Oh,
like
thank you.
for you not to like know some of this stuff is that I don't think it's been presented in a way that we're presenting it now.
I don't think that there's any education around this stuff.
Right. And so the idea is that if I could explain to you how the brain works around your addiction and how the trauma is involved and how all of these things all fit together and give you a neurological basis for recovery, then you're more likely to go do the things that you need to go do with the idea that, hey, here's what's happening inside of your brain. Here's how you're rebuilding these particular pathways. Here's what you're trying to address. You're trying to quiet down this hyperactivity.
Okay, so uh, can trauma recovery? So how easier is it even possible really to recover from trauma without recovery work?
Is it possible to recover from?
To heal like the
Yeah,
brain, is it possible to heal the brain without doing trauma work?
I think you have to do some type of work in some way, shape, or form to like build prefrontal pathways.
Yeah.
And I think it's just more effective when it's done in the setting of like a therapist. There's nothing like having someone that's fully devoted to you for 1 hour that's a specialist in trauma, right? Or a specialist and has seen multiple people come in with the same affliction as you and to be able to like see the pattern already. Because I like to think I'm super unique. I like to think like I'm the special, unique snowflake. And I am, but I'm also like a snowflake
Yeah.
amongst all these other snowflakes. And the person that did my EMDR work, like she knew exactly, like she had known me for about 2 years professionally
Mm-hmm.
at the place that I worked at before. And when I went to her and I was like, hey, like I would like to do my EMDR work, she's like, great. Tell me 3 trauma points, right? And I was like, well, I've got this from my early childhood about, abandonment, all that stuff. And then I got my house burning down at the age of this. And then I've got this other thing that's just really nebulous and unclear. She's like, great, we'll start right there. And I was like, okay. And like within 5 minutes, right? 5 minutes of doing EMDR, like all the stuff that I'd stuffed away for, let's see, 15 to 35, right? So, no,
20.
no, 15.
Yeah, 20 years.
No, I'm sorry, 15 to 45.
30 years.
30 years, right? All came flooding back all at once.
Okay, was it vivid memories, like visual memory? Like,
Yeah, it was all like, I was just like, this is ridiculous, right?
yeah.
Like, are you serious? And the thing is, if I'd seen myself come into clinic and like, someone told me that story, I'd be like, I know what you're talking. I know what you're like. I've seen enough of the patterns, but
Yeah.
like I saw, I couldn't see my own stuff.
Self cannot critique self.
Right. We've talked about that before, and so I think that trauma recovery can happen slowly without therapy, but if you want to supercharge it and get at it quickly, like with a professional, like I would highly encourage you to do that if you're in a space to do that. But I also think that it's better to have a container created first before you go into that.
Yeah, the importance of that container. Uh, you ever seen those tops?
Yeah. Like
Like, like a top. You
yeah,
like spin
dude,
it.
those were big in India.
Okay,
Right?
yeah.
When I was a kid,
Oh, that's
what
right. I saw that there's a movie about it. I think it's
Uh,
called Tops.
oh, really? In
Yeah.
India?
Yeah.
Okay.
Okay. Anyway, I think of it as like when you are doing trauma work, you're like spinning a top, and when it spins, it can go fucking anywhere.
Yeah.
But if you put it in a box, it'll just do
Go in
this.
that same thing. Yeah.
Yeah.
Yeah. Absolutely. Right. And you don't want it spilling out or spilling over.
Yeah.
I mean, I've seen more people when I was working at the treatment facility, some of the people that would come back in, right? I would be like, "You were just here like 2 or 3 months ago, right?" I'm like, they're like, "What happened?" They're like, "Oh, I started doing EMDR," and I would
Oh,
hear that story over and over and over again, and I was like, "Oh," and they're like, "Yeah, like
and it led
it
to a relapse.
led to a relapse,"
Yeah.
and I really believe that doing it too early is an issue, right?
For
Especially if you
sure.
don't have the support around you, or if somebody isn't isn't trained or has enough experience. Like I always, anyone that asks me for who would you go to for EMDR, right? I always send them to like the same like 3 people because they've got years of experience doing it. And what's most important to me is the number of times or how long you've been practicing EMDR before I would send someone to you.
Okay.
Because the problem is and the fear is that you go in there and they open something up without properly closing you back up or
Yeah.
leaving you with like the proper tools to like be able to like handle that or deal with that.
So one of the things around EMDR that I was just completely ignorant about. So when I first heard about EMDR, the way that it was explained to me, it was like, oh yeah, it's some hogwash, soft science. Like there is nothing to it.
Right. And
And
that's what I thought too when I first heard
really,
about it. I was like, "What? Like, you want me to click some paddles and like move my eyes around? Like,
yeah,
come on,
yeah,
right?
yeah,
Like,
yeah,
come on."
yeah. And then like I haven't done it. But the next guy that explained it to me, he was trying to get me to come in to do it,
Uh huh.
and he showed me like the machine, and I was like, "Wait, what is this?" He was like, "Yeah, this is EMDR."
Uh huh.
I was like, "So it isn't like lights and like all this stuff?" And he was like, "No, no, no." He was like, "Really, what you're doing is like tricking your brain basically into remembering things." I
Yeah.
was like, "Really?" Like, yeah, okay.
Yeah.
So when
It's bringing up fragmented memories
yeah,
from points of trauma, and so what it's doing is it's helping you to recollect those memories by the last memory that you had, and then it tricks you into finding the next memory, finding the next memory, and finding the next memory, and then building those pathways into that memory.
mm,
So of my trauma point, I had everything up until it happened, right? And I was like, "This is the last thing I remember." And she was like, "Great, now what's happened?" Like they would do the thing, and they're like, "Now what? Now what? Now what?"
really?
And I was just like, "Oh, are you kidding me with this? Like this is ridiculous."
Did you ever have a chance to address that with that person?
No.
Okay.
Oh, yes, yes, but it was in a I never want to talk to you again like way.
Yeah.
And then that lasted for about 2 years, and then it was we're in a better place now.
Okay.
Yeah.
Okay. Why do opioid this is such why do opioids feel like love?
Why do they feel like love, Matt?
Uh,
Why
I don't know why, but
does it really feel like love?
it feels better than so I don't know. Love is how do you explain love?
I don't know, like body sensation type stuff.
Yeah. So then yeah, it definitely feels like
Right, like
love.
an over warm, like a warm sensation all over your body.
Cuz
It suppresses stress hormones, mimics emotional connection, leads to like fear, calms down fear and loneliness. It's
okay.
basically like it's basically tricking your brain right into thinking that you're safe,
Okay. Then yeah.
right? And
Yeah,
so then
definitely.
that's what love is to me, right? That feeling of like safety and security.
Yeah. So I tell people all the time that heroin told me a very consistent but very believable lie that everything was going to be okay.
Yeah. Yes, consistently, right? And why
Consistently.
would you not go back to that,
Hmm.
right? That sounds amazing,
Yeah.
right?
And I knew at a certain point that everything wasn't going to be okay, but at that point it didn't matter because I still felt like it was going to be okay.
How much of that was the feeling that you got that you weren't going to be in withdrawal anymore?
I used heroin for 17 years almost.
Okay.
That was 16 and a half years of it.
Of what? Of the not getting into
Yeah.
withdrawal?
Uh-huh.
So the first 6 months we're like, okay, this will make me feel better. And then the
Yeah.
next 16 and a half years, we're like, I don't want to go into withdrawal.
Yeah. Okay, because one thing that I've recently learned is that the pathways are so burned into my brain around my predisposition for this drug
Uh huh.
that I could be stone cold sober for the longest I put together was 64 days
Okay.
in that time period. I could go from stone cold sober to using for 24 hours and be in withdrawal the next morning and only have used for 24 hours. So I was
And be
just,
in withdrawal the next day.
yeah,
Yeah, like
yeah,
that's the kindling effect,
yeah,
right? Like as you use and withdraw, right? You are more likely to get into a withdrawal. That's why people that detox from alcohol come back in, detox from alcohol come back in, right? The very next time that they do it, it's like it's the possibility of it being even worse,
yeah.
right? Because your brain gets really good at withdrawing, right? And it
Hmm.
gets really good at, you know, getting yourself into a seizure.
Yeah, yeah. So I mean, the the um, the addiction part of my heroin use,
Mm-hmm.
very little of it had to do with like seeking a feeling of like what a typical heroin high is. A lot of it is really like centered around like the mental and emotional part that I was trying to run away from. It wasn't, oh, I'm gonna do this drug and I'm gonna just feel amazing for the next five
Mm-hmm.
months. It was like I needed to quiet the amygdala right now, and that was my DOC. So that's what I used.
Yeah.
And immediately though, I would be dependent on it immediately. So a lot of it was chasing not getting sick.
Right.
A lot of it.
Interesting. Um, so
So how can trauma survivors stay feeling safe early in recovery?
I mean, that's such a difficult question to
Okay, let
like
me
answer, right?
let me
Like,
ask you a different way too.
okay.
Um, People who there are different traumas, right? There's different levels of trauma additionally, but there's different types of trauma, as in there is sexual trauma, abuse, physical trauma, neglect, abandonment, all this stuff.
Yeah.
It leaves uh, like a traumatic, what we used to say was scarring, right? That there was scarring on the amygdala. How does somebody enter a place of safety long enough to either address it or like fight through whatever it is that they're feeling?
Yeah. That's such a subjective question, right? Because like everyone has a different level of need to feel safe, right? And so the thing is, like, for some people, it may not be possible going back into your old environment again over and over and over again. It may not even be possible going into like mixed meetings, right? Like, especially if like some of your trauma is like sexual trauma, right? Going
Hmm.
into a meeting with like a mixed meeting is just going to reactivate you. And it may be that you have to go to a men's only meeting or a women's only meeting, or you have to like find one that feels really safe, right? And so I don't know the easy answer to that. I mean, I could just be like sober living for everybody, right? But there's some people that are like they don't even feel safe in sober living, right? Because there's other things going on.
Yeah.
So I don't. My sponsor and I were having this discussion the other day because I was talking to him about this chapter, right? Feeling safe and like not re-triggering things. And he's like, it's impossible. Like you have to let them know that it's not possible to go without being triggered. The goal is how do you get to a place where you're not triggered as often, but that if you are triggered, that you have a place to go and like down regulate from it.
So where does coping skills play into this? Because as far as like the reactivation of trauma is concerned, from my experience, I would go from perfectly fine to reactivated to using immediately.
Yeah. And I think it takes time to get away from that pathway. Like that, like with neuroplasticity, if that pathway is so embedded and so like, like strong that as soon as like you feel anything, like you go right back to it.
Yeah.
It's how do you start building new pathways of just that one time not doing it? Like a new thought in your head of like, hey, instead of going and using, I'm going to go to a meeting. And then just reinforcing that over and over and over again. Those pathways are really deep. Like almost Grand Canyon deep.
Oh yeah, you know what I would tell people? You know those cartoons where it's like somebody is walking back and forth, and they you see them get lower and
Yeah,
lower and
yeah,
lower
yeah,
to
yeah.
the ground.
Yep.
That's what the
That's
pathways
exactly
look
it.
like.
Yep. And so how do you change out of that groove that you're in, or that
Yeah.
rut that you're in, right? Like it's gonna take you starting a new path, right? But you have to start walking down it over and over and over again to get it as deep as that previous one was, or hopefully that other one starts to decay away because you're not using it.
Do you remember my question around preferred pathways?
Remind me.
So, is there a higher affinity for a given pathway based on how much that pathway has been used?
Yeah, that's the whole point of neuroplasticity,
Okay.
right? That becomes the preferred pathway.
Okay.
So my go-to default mechanism for any feeling that I ever had was to go drink, and that was my only coping mechanism.
Mm-hmm.
And so as I got into recovery, I got more and more and more coping mechanisms, right?
Yeah.
It wasn't going to go drink anymore, right? It was like call your sponsor, right? That was a pathway. Go to a meeting. That was a pathway. Call another person in recovery. Go for a walk, right? Now it's hey, go to the gym. That's
Yeah.
been helpful lately.
Yeah.
Or sometimes it was like, hey, like let's go get some Haagen Dazs or some
Oh,
Ben and Jerry's, right?
yeah.
That was an issue too.
Talk
But
about receptors and like
yeah, that's
dopamine
deadly, right?
rushes.
Like
Yeah.
I can eat the whole container of Ben and Jerry's, especially when I was going through a breakup.
Oh
Like that
yeah.
was my go-to for
Ice
breakup
cream.
stuff. Yeah, and a lot of it. Like I'd go to the liquor store and I'd buy like four tubs of it, and then by the time I finished the first one, I'd be like comatose out, right? But I knew I had three left for the next 3 days just to like get through it all.
It's amazing how many calories are in that little bucket.
The calories are in there
So the chocolate chip cookie dough, Ben and Jerry's chocolate chip cookie dough, it's like 1,400 calories
for the whole
for the
thing.
whole thing. But that's
Yeah,
one sitting.
yeah, that's easily one sitting,
Yeah.
right? Like who's how is that not one
What
sitting
non-addict, what addict is not eating that whole thing?
on the first pass? Like,
Yeah.
I mean, only if it was frozen, I had to like chip away at it the entire time. Like
That yeah,
that
but
gets annoying.
that only lasts for so long.
Yeah.
Okay. So why does environment matter so much?
And this is going back to the stuff that we were talking about, right? It's just not getting reactivated over and over and over again, right? And then building some container that feels safe.
Yeah.
And that safety is probably the most important thing so that we're not reactivating. You cannot build new prefrontal pathways during periods of fight or flight. Like, that's probably the most important thing that I can tell you, right? Is that in order for you to learn a new pathway or to build new pathways and to reinforce those, or the fastest way to do that is to feel safe.
Yeah.
And if you're in fight or flight, that's not going to be happening as often because I'm not thinking about the message, right? I'm
Yeah.
not thinking about solution, right? I didn't go into a meeting like in a fight or flight state being like, oh, where's my solution, right? It took me like 20 or 30 minutes to like actually
Down regulate.
down
Get
regulate,
into the.
feel safe, and then I could actually listen to what was going on.
Okay. Um, I always tell people that like it's really hard to send a healing person back into a sick situation, expect them to stay healing, right?
Yeah,
And so, um, the next question
yeah.
is, uh, can people recover like at the scene of the crime?
Yeah, I love it. The scene of the crime, right? I don't know. Can you? I mean,
I
I would say that for most people, going back into the same environment over and over and over again is not useful, and that there has to be some degree of change that's occurring so that you can actually build those new pathways, especially if you're getting your trauma reactivated over and over and over again.
Yeah, and so really what we're talking about is like the living girlfriend that's abusive,
Yep.
or the boyfriend that's
Or
abusive,
or the job that's toxic,
the job that's toxic.
the family dynamic that just won't go away.
Yeah,
That's like you're getting re-stressed out by that over and over and over again. Uh, child that's sick.
oh
That
yeah,
that's been a big one
oh
for
for
some
sure.
people. Financial insecurities, not getting paid, having debt, having looming court cases. I mean, all those things are things that are laying or like kind of sitting on the back of your head, right, the entire time, and you never have a chance to like down regulate.
Yeah,
That was me for the first, I think, 3 months of my recovery. I was supposed to go report to the Texas PHP. right? And so I was like, every single day, I was like, I'm gonna lose my license. I'm gonna lose my license. I'm gonna lose my
Oh, so
license.
you just didn't do it.
So no, I did do it.
No, but for those months, you were like, when were you supposed to report?
As soon as I no, before I could leave treatment, I had to do everything that they wanted me to do
Okay.
in order for me to come back to residency, and that was one of the stipulations.
So did you just put it off?
No, I made the appointment, but the appointment wasn't for like another month and a half
Oh.
because I had to drive up to Austin to go do it.
So you're like, ugh.
I'm sitting there for a month and a half, being like, I'm fucked. I'm like screwed. This is never gonna work out, right?
Yeah.
I just spent the last. God, at that point, how many years had I been in? 2005 is when I went to Georgetown, and I got into recovery in 2014.
So 9 years.
So I was like, I just wasted the last 10 years of my life.
Yeah.
Because they won't let me be a doctor.
Yeah, because this is education, like formal education, training, fellowships,
all that stuff.
Yeah.
Right, and so it had been, yeah, 2, 6.
Plus all the student debt.
Yeah, and I was like, I owe $30,000, right? I'm screwed. And so like I could not be still.
Yeah.
Until that was resolved.
So Taylor always says it's nearly impossible to get well in the place that got you sick.
Yeah.
Right. And I know that like a lot of people will say like pulling a geographical isn't going to solve shit because everywhere you go,
but geographical is the assumption you're only doing it for geographic changes. You're not doing anything else.
Right. Yeah. Yeah. Well, so you know what Taylor did, right?
You said for a Foreign Legion?
Yeah. He went to France.
Yeah. That's crazy, right?
To the French Foreign Legion.
Those guys are badasses.
Dude, those guys are crazy.
Yeah.
You should hear his stories. Do you subscribe to his channel?
I think I follow him.
Okay.
Yeah, but I didn't subscribe to his
channel.
Dude,
you should listen to some of his like early stuff because he was still when he started filming, he was still in the barracks at
really?
the French Foreign Legion in his uniform and everything.
When he first got onto Instagram?
And YouTube, yeah.
Okay.
Mm-hmm.
Sounds like fun.
I mean,
how long has that been?
It's been 1.5 years since he got out.
How long was he in there for?
Almost 5 years.
Okay, so he's been doing stuff for 6 years now.
Yeah. He's got a decent amount of time between him and like all of the bullshit.
So I mean, we talk about like just refining the message, right, over and over and over again, and finding like what your voice is and who the people that you're going to be talking to is.
Yeah, it's really interesting to see like the evolution of him. I didn't know him before, right? But like seeing where he's at and where he comes from is pretty cool. So how does connection heal the brain?
Oxytocin, right? We talk about that all the time. Shared vulnerabilities, reduces the cortisol levels, empathy rewires the limbic system. I mean, these are all the important aspects of the recovery process. And for me, the oxytocin is the start of it, right? The other thing that's been interesting that we haven't talked about a lot is the mirror neurons. Do you know what mirror neurons are?
No.
Mirror neurons are these neurons that they thought only kids had as they were developing. And so it's a mimicking neuron. And so what happens is that the neuron fires, right, when I pick up a glass, right? But if you watch me pick up a glass, there's a mirroring neuron inside of your brain that fires too.
Really?
And so you learn by watching someone else do that particular thing.
So this is like a monkey see, monkey do.
So all the images that you would look on Google to look up mirror neurons, the examples are of a monkey.
Really?
Picking up something. Yeah.
That's so
funny. That's how we learn, right? By mirroring and copying other people. And so those particular mirror neurons, right, are important for recovery is because you are learning from the people that are around you. Right, and then the recovery support community replicates family safety, and then getting those hugs. Right, for me, it's all about getting those 10 seconds of hugs every day. Right, that's where the oxytocin comes from. But it can't be like those hugs where you're getting the pat on the back and stuff like that. It's got to be one of those like a real hug, like a real like 2 or 3 second hug, not one of these like like ass out shoulder like tap things. And then increased laughter, increases serotonin. What else is there? And then consistency, right? Builds that process of like safety over and over and over again.
Okay, so why is isolation so dangerous?
I mean, that's where my disease existed, right? Like me alone by myself, not really having any connection, having the cortisol spikes at home, uh, just thinking about what can I do to not be in this particular feeling. I know what would change this, right? A drink would make this really, really good. And so it's like I had no accountability. I was like staying at home by myself. The fear returns easily. You get disconnected. And the absence of oxytocin, right, leads to loneliness. And so it's really important to rebuild social trust
Yeah, but why?
for the oxytocin,
Okay.
right? I mean, that for me is the key to the beginnings of recovery because the oxytocin allows for me to feel safe in the context of a group. And then being in that context of a group then allows for me to build those new prefrontal pathways because they're teaching me by implanting new ideas into my brain. I learned so much in the meetings, it was insane. Like that was just an ideal spot to like learn these new principles and these like new ways of being.
Yeah.
Like what did they always say? If you hang around with four rich people, you'll be the fifth,
Yeah. Yeah,
right?
it's
So
also like the whole when you hang out at a barber shop long enough, you're gonna get your haircut.
haircut, right? So if I sit in meetings long enough and I just listened, like I'm going to absorb the things that they're saying and the things that they're telling me.
Okay, let me ask you this then. What about people who I'm really asking this too. What about people who go into meetings or let's say they're chronic relapsers or let's say they've been labeled as treatment resistant.
Okay.
What are we telling them to get them to re-engage with AA?
Um, we are giving them this format,
Mm-hmm.
this process, and to be like, your job is not to just go to meetings. Your job is to feel safe there.
Okay.
And if you cannot feel safe in that particular meeting for whatever reason, maybe it's because you've burned some bridges or like you've got this reputation or you're that person that does this, right? Maybe there's a biological thing that's going on underneath all of that. Maybe you've got the cycling mood disorder. Maybe you've got the algorithmia that we talk about. Is to come into clinic and let's talk about that and see if that's the issue. But let's see if we can stabilize that. But your job is to go in and build community again. And if you can't do it at the place you've been going to, right, you may have to go find some other place to do that at. Right? Because a lot of people when they relapse over and over and over again, like they build up wreckage,
Yeah.
right? And that wreckage does not allow for them to feel safe. Not that they're not welcomed or they're not invited into the rooms, right? Like we don't shoot our wounded, but at the same time, right, that thought is still in the back of their head, right?
Yeah.
Until I like go and like I go and talk to those people, or like I go make my amends, or I like I do the thing.
Yeah. Yeah. I think that there's a lot of people out there that by reframing what but by hearing what we're talking about and reframing whatever it is that they're going into those rooms for, I think a lot more people will end up going in and getting what they need out of these rooms. Um, okay, so what is medication assisted treatment?
Let me just tell Amy that I'm in.
You gonna answer? Or she didn't call?
No, the new patient's here.
Oh, okay.
Well, she called 3 times. I should call her back.
Okay.
Give me a second, all right? You keep talking.
Okay. Who is here? Who's in the chat right now?
Hey, I'm still in the podcast, but
Okay, what do you guys want me to talk about? You gotta message me though. Dr. Shah had to step away. He is dealing with a patient. Chris. Is this Chris Hopper? I think it is. Chris, what's up, dude? Okay, there's a guy named Miscellaneous in here. That guy needs to get blocked. I need to get a moderator. Chris, do you want to be the moderator? Let's see. How do I do this? Thank you, Mr. Buttersworth. See you next time. Thank you for coming in and participating. Moderate. I have somebody in here, Chris. I have somebody in here that's making. I don't know if you guys can see all of the chats or if it's auto moderating people's stuff out, but I need somebody. I mean, I didn't get that many people on, but eventually, this guy's making like super crazy comments, and we're gonna need somebody to kind of weed that stuff out. So I don't know if that's something that you might want to do.
Sorry about that, you guys.
Okay. So, how do you rebuild social trust? And let me ask you, let me kind of make this more pointed.
Okay.
How do you rebuild social trust after you have burned bridges over and over and over?
That's going to be tough, right? I
Mm-hmm.
mean, I would love to say that you can come back and the room is going to be safe for you and it's going to be like what you expected, but like there really is stigma that happens after a certain number of times, right?
Yeah.
Like people are like, oh, like they pick up another chip, right? It's not everybody. Like a lot of the old timers are like really compassionate and really kind, but like if you're building your social support network around that, like some people are going to be like, I can't do this again, right? Like you've done this so many times. And that was definitely one of the people that I knew from the rooms that like he was a frequent relapser, right? Like he's definitely in the book over and over and over again. And eventually like he just had to move, right? He moved out of the state.
Really?
Yeah, because there just wasn't he had burned so many bridges here that like I, I cannot believe that he would have been able to find recovery here. My hope is that he's sober wherever he's at, but it was difficult for him in the rooms, and then he went to like NA for a while, then he came back, and then he went to like something else for a while. But it was just a constant relapser, right? Like every 3 or 4 months. And so I don't know the answer to that. I would love to say that it's like the rooms are, always a safe space and always gonna be compassionate, but that's not human nature,
Okay.
right? I would love for it to be different. Like, what are your thoughts on that?
I think that there is room to grow, right?
Yeah,
I don't think that this is what I would suggest. If you run into friction points in your recovery,
right.
you're going to change something, right? Something's you're going to do something different. And so if you run into friction points in a given group, go to a different group.
Yes.
Go to a different meeting. Go to a different room.
Yeah.
Go to a different clubhouse. Do something different, but don't throw the
No,
baby out with the bathwater.
right. And so the process is solid, or like fundamentally it's solid.
Yeah, there's sound doctrine like where you find solid recovery, right?
Right.
The problem is that not everybody fits in any given group.
And I would propose to you that like the model that we're proposing is going to significantly reduce the rates of people relapsing over and over and over again.
Chris just brought something really good up, right? He says the meeting value only comes from tradition 5 where, it's the therapeutic value. Like it's one addict helping another.
Helping another alcoholic. That's 100% true, right? And so all of that goes back to the feeling of safety and the oxytocin you were deriving from that.
Mhm.
So we've talked about oxytocin is derived from like 4 or 5 different things, right? In males, it's 3 in particular. It is feeling safe in a group that you've bonded with,
Mhm.
altruistically helping someone without wanting or needing anything in return, and then sex. But that sex is being in the context of a healthy, committed relationship. And then for women, it's childbirth and breastfeeding, all because they have to bond with the baby at some point.
Okay.
Yeah.
So let's switch gears a little bit.
Okay.
So MAT, there's a lot of talk about this. It's kind of a hotly debated thing,
Uh,
specifically in the recovery community.
right.
Medication assisted treatment. But what is it? And in my experience, a lot of people forget about the T part.
Right.
So what is it?
So typically, classically, the two that we use are either methadone, Suboxone, or I mean, Vivitrol is considered, or like the long-acting naltrexone is considered medication-assisted treatment. And so Suboxone is a partial agonist, right, which has a ceiling effect on the opiate response, and the methadone is a full agonist, right? And so they differ in terms of like their safety profiles. Um, Suboxone is safer in terms of respiratory profile. Doesn't really have the respiratory depression that you would normally see coming from that. Methadone has a higher tolerance, Suboxone is outpatient friendly.
Mm-hmm.
Methadone, you have to like go in every couple of days. They at most give you a week long supply of it. Both reduce the relapse risks, but if they're used for the purpose of what they're supposed to be used for, right? There's monitoring to ensure that they're dosing it safely. Usually, what you get with the Suboxone is, did you get you go in for a week, you get a week supply, then you go in the next week, you get another week supply, then you go in another week, you get 2 week supply, then you like go and you get 2 week
You
supply,
said
or
Suboxone.
yeah, it's Suboxone
I never had that. So after you and then after leaving treatment, I got an online one and I was getting a month at a
right off the
time.
bat. Yep, that's what typically has been happening with
Mm-hmm.
the online ones. Um, Yeah, and I don't know enough about the online model, but I know that it was just recently that they passed laws that said that you could prescribe it online.
Yeah. So again, this is part of the slippery slope around it, and this is where the discipline and dedication to your recovery is massively important,
Right?
because we're addicts. We're gonna find avenues to be able
Yeah.
to manipulate and abuse. The thing that I There's two things that I want to say about this is that I've done both of those, and methadone is not conducive for me and a good solid recovery.
What does it feel like?
Methadone,
Yeah.
again, I wasn't clean when I
Okay.
was using it, so I know that there's a lot of people that go out there and abuse it.
They like mix and match.
Well, you can still get, it isn't a blocker, so
Okay, so you
people
can
are
still get
still.
high on top
Hmm.
of that.
Yeah, and so that's why I'm saying, like, it wouldn't be a
But
conducive
don't you
thing.
have to drink it in front of them?
Hmm.
So you drink it in front of them, and
Hmm.
then you still go out and you get high.
So this is what it was. I was using it so that I wouldn't get sick, because I lived an hour and a half from where I got my drugs,
Okay.
and so there was always times where like I would need it basically, right? And so I just got on it and stayed on it. And when I met Megan, I was strung out on heroin and methadone.
That's how you met Megan.
Mm, actually, we met because I was trying to get it paid for, and
Get what paid for?
the methadone.
Okay,
And so I was at the welfare clinic, and she was trying to basically do the same thing. We met at a welfare clinic.
that's so cool.
Mm-hmm. That's funny, huh? So Chris also said it is another way to combat withdrawal. Supposedly a step down process, although detox is detox. Assistance is sometimes needed. It goes okay. Although assistance is needed at times, we go through dependency. Oh, the dependency of it should ease, right? That's the problem, though, right? Is less dependent on substances, more reliant on good orderly direction, right?
Yeah, so
God.
I mean that's the goal, right? So
Mm-hmm.
for me, whenever we're using Suboxone, the goal is to give you enough space between the searching and seeking to stabilize your life so you can actually build a life worth living.
Yeah,
And then once you've built a life worth living is when we start to come off of the Suboxone.
yeah,
Whether that takes a year, whether that takes 2 years, but the goal is to come off of it. And so I never want to keep my patients on it long term, but some of them get this idea that that's the solution for them when it's really not. They don't want to go through the withdrawal side of it.
yeah. It's a slippery slope.
Yeah,
It's really hard to find
I,
that happy medium.
and so how is the concern? So here's two concerns, right? Is the concern that they're using and they're on the Suboxone, or is the concern that they're on the Suboxone and they don't actually find the treatment side of it, and so they're just relying on the Suboxone?
So there's two things that I hear like a lot. If you're on Suboxone, you block your contact with that connection isn't even possible,
Uh huh.
right? You block that contact, the ability to have that connection to God is completely blocked off because you're on a substance.
Okay.
I hear that all the time.
Okay.
Okay, so there's that part of it where that could be it. I don't know. I don't know if that's the truth or not.
So
But
I have this spiritual idea, right? That the closer I am to a spiritual experience, it's when I'm in a lower dopamine state and a higher oxytocin state.
oh yeah,
And
I
so the goal is to slowly replace the dopamine with the
mm-hmm.
oxytocin. And so as I'm coming into recovery and doing those aspects of it, right, I'm getting the dopamine effect, but I'm also getting the oxytocin. And so
So
it's balancing that out.
okay, so totally agree with that. The two things, right, is you don't have the ability to have that conscious contact because the chemical is blocking you from having that.
Yeah.
The other thing, which is exactly what Chris just said, is the reliance.
Right.
You are still dependent on a chemical. So
Yes.
you're trying to escape a chemical hook with another chemical hook.
And so that's where he was talking about the
Good orderly.
gradual, no, the gradual, right? The gradations of it, right?
Mm-hmm.
So I'm not using it as, if I can't get you to that spiritual experience right off the bat, right? I'm okay with you moving towards that in a stepwise fashion.
Yeah, yeah,
As long as it's like, I mean, if you're on the street slamming fentanyl, right? And your option is slamming some fentanyl or being on Suboxone, I'm going to be like, I'm going to be okay with you being on Suboxone,
yeah, for sure.
right? And that's complete harm reduction for me. I
Mm-hmm.
would much rather you be there, right? And going to work and trying to have a productive life than worrying about doing the whole fentanyl thing, right? And then the idea is that not everyone's spiritual journey is going to be the same as my spiritual journey,
Yeah,
right? I don't need everyone to find God. I just need you to go and do whatever it is that you're meant to do in this lifetime.
yeah, and I think that that kicks the door open. All right, we talk about springboards, right? Like using each springboard properly will
Mm-hmm.
eventually get you into these situations where you are having an interaction with your higher power.
Mm-hmm.
And the next question around this is why is Matt so stigmatized?
Who they asked you that?
No, I'm asking you.
Why is Matt so stigmatized
Hmm.
about what around the Suboxone?
Why is MAT? Why is medication assisted?
Oh, I thought you were like, why is Matt so
No, no,
stigmatized?
no,
I
no,
was
no,
like,
no.
I don't know, Matt. Why are you so stigmatized? I don't know what Matt's deal is, right? Do you want to get into? Do you want to do a whole episode on why Matt's so stigmatized?
We need a couple.
So Matt, it's why is Matt so specifically Suboxone and like methadone, right?
Yeah.
Why is it? Because I mean, I don't see any stigma around
So
naltrexone or Vivitrol at all,
for sure.
right? So I think it's I saw it all the time when I went to California, right? There would be people that would yell out in meetings, Suboxone's not sober, right? And I was like, well, I mean, that's not for you to say.
Mm.
And I think it's goes back to thine own self be true. But there's a lot of I think it's a lot of fear around the different people coming into spaces that were originally for a very particular demographic of
Mm-hmm.
people. And so if somebody's looking for recovery in the rooms of AA and they're on Suboxone, like I think there's fear from the old timers of like these are the people coming into like this particular space when this space has a primary purpose, right? Is to carry the message to the alcoholic, not to the dude on Suboxone,
Okay.
right? And so I get it. I understand what they're saying from a primary purpose point of view or a primary purpose perspective. I it's tough, right? Because there's always the evolution of the program. There's evolution of like recovery, the evolution of things that are happening in society today, right? And so like how do you carry the message to the most number of people?
Okay.
But based upon primary purpose, that message is not for you.
Yeah.
But I don't know, right? Like I don't know why it's like there are certain rooms that it's not an issue at all,
Mm-hmm.
right? There's a lot of kind and compassionate ones that are like, great, awesome. You haven't had a drink? That sounds great, dude. You're coming to meetings? Welcome back, right? And so I don't know if it's everybody,
Yeah.
right? And so is it really that stigmatized, or is it just the loud people that are there? I don't know,
It's a good question.
right? And
So
so are you being triggered by the fact that like someone came up to you and you were like you heard that person and that's what your memory of it is, or were there like 30 really compassionate people that were like, no, keep coming back,
yeah.
and there was just one asshole that was like, we don't talk about that in these rooms? That sounds like his own stuff.
Yeah. So here's something else, right? Chris said, if I'm on Matt, I'm blocking my ability to truly enjoy sobriety or to learn from clean experiences. And still building experiences that you may not remember.
That you may not remember.
Yeah, and so I think what he's talking about, and I could be wrong, but like there, you always see like those people that are in the corner of the room
Yeah.
that obviously took way more than they were supposed to.
Oh, really?
Yeah,
How do you tell?
they're sleeping.
Okay. I just assumed those guys were on kratom or that they were high.
So I know we work with a Bodine, right?
Uh huh.
And one of the things around Bodine and they have a no mat policy
Okay.
because when you got the guy that's like asleep on the couch, even if he's just sleeping, everybody's going, "Why is this guy nodding out?"
Yeah.
It creates division, but also there's like a level of like resentment that can be built up where it's like this guy is still
Yeah.
doing this
Yeah. Yeah.
stuff,
There's separation there.
Mm-hmm.
But they have mat friendly houses.
Oh yeah, they do. Where
Yeah.
there's one here where it's like you cannot participate in the
Unless
program
you're in,
unless you're.
they're part of a UT study,
Mm-hmm.
right? To see the benefits of mat and of
Sober living.
sober living at the
Mm-hmm.
same time. That's the house I went to.
Really?
That's the one I lived in.
Wait, has it been around that long?
Yeah.
It was free.
No. The house that I went to, right, was just a regular old sober living house. It
Okay.
wasn't until the Heroes program came in and UT were doing the studies
Okay.
that it switched over to that.
Okay.
Yeah.
Okay. So, are there side effects to Matt?
So sometimes for the Suboxone, there's like the typical opioid stuff, right? Some people get like constipation from it,
Okay.
but for the most part, it's pretty clean. At least the Suboxone is. I haven't really heard that many side effects from it.
Yeah, methadone is not a clean
Okay.
because it is I think it's a full agonist,
Yeah.
and there is no blocker. You can still get high on it, basically.
Right.
So I don't know, that's a very, very slippery slope. I don't think that it's conducive to a good, strong recovery. So if I seldom remember. When I am enhanced, I'm avoiding my ability to remember things as the chemicals impair my memory. The longer I spend clean, the longer my mind has to be clear.
Yeah, I would agree with you on that.
So
But I mean, I don't
that's
know
what
about I
Chris
don't know
just said
about
that.
impaired memory, right? What is that? Like your your experience is filtered by the drug that you're currently using at that time. So
Hmm.
it's not as you're wearing you're wearing like sunglasses, and so your vision isn't completely clear. It's filtered through that. So I can agree with you on that. All of your experiences are filtered through that. But this goes back to I'm not going to be one to judge your level of spiritual growth or your level of recovery.
Yeah, I ask people all the time, like, so what about the guy who was living under a bridge 5 years ago? He was slamming heroin and meth or whatever, and now he's on Suboxone. Like
Yeah.
that
Sounds
level.
amazing.
Yeah.
Dude, good job. Right? You got your life back together. You've got a job now. You've got an
Yeah.
apartment. Like,
Yeah,
that's
yeah.
amazing.
Okay, but what if he doesn't have all that? What if this dude is just not using? And this goes back to the
Not using and doing what?
nothing.
Nothing with it. I mean, where's he living then?
Yeah, I mean,
Still living underneath the bridge?
yeah,
But not doing meth
and
and
heroin.
heroin? That sounds amazing.
Okay.
Good job, dude.
Yeah. Okay. All right. So, how is Matt monitored clinically?
Okay, like routine drug test,
Really?
right? Yeah. I mean, most places do that. Sometimes they do pill counts. We do the prescription monitoring program. Like, I will double check to make sure that they are not like taking benzos or getting benzos prescribed from someone else. And then checking side effects regularly, mood tracking, sleep function, encouraging meeting attendance. I kind of make sure that they are seeing a therapist or they have a therapist of some sort, so that I know that I can always check in with somebody. And then just gradual, like adjustment of doses. My goal is always to get the patients off of it, right?
Yeah.
But I'm not going to be one that forces them off of it. I'm going to wait for them to be like, "Hey, you ready yet? Hey, you ready yet? Hey, you ready yet?" Some people just aren't going to be, right? They just never are. And I've been very judicious about who I'm taking into clinic these days. I mean, just one based upon I'm like I don't have the cycles for everybody, And then two, I'm trying to like work on proving the model.
Mm-hmm.
So that's of more importance to me than like just taking anyone into clinic. And so I'm taking like less and less Suboxone patients because we talked about the Pareto principle. 80% of the patients will take up 20% of your time, but 20% of their patients will take up 80% of your
80% of your
time.
time.
And that has been so true for me. It's unbelievable. Yeah.
Okay, switch gears again.
Okay.
Okay, withdrawal management and early stabilization.
Right.
Okay, what is the goal of withdrawal care?
The goal of withdrawal care is just to make sure that you're comfortable enough in the first couple of days so that I can get you to treatment.
Okay,
That's my goal. My goal is I don't like to bring anyone in for detox or withdrawal if you're not going to go do something. Right?
really?
What are we doing here?
Okay, so
Right? And
is there
I
questions around that?
for the facility,
Yeah.
yeah, we do. But are they always adhered to? Not always.
Okay.
Right? But I mean that's the ideal.
So if somebody is just like, I don't know.
We still take them, right? But then I'm spending 3 days with them being like, where are you gonna go? What are you gonna do?
Okay.
What is this something happening? Right? And then you know the ones that are just coming in for a bed. And then
Oh.
you're not doing anything. And then then they'll be back like 2 months later.
Dude, that sounds so miserable.
It is. It's so miserable.
Yeah, that sounds miserable. For the
Um,
person in the bed, it sounds miserable.
it's not a good life. Especially if you're going from like we've been operating for 3 years now and we have enough frequent flyers where I'm just like, no,
Frequent flyers
no, like we're
at
not.
detox.
Yeah, but they're not coming in. Some of them aren't coming in for detox. Some of them don't come in. There's we you would not believe our extensive do not admit list. Like it's long.
Really?
Yeah, there's like no, we're not taking this person back for a
Wow.
multitude of reasons. But some of them are like they end up being drug seeking, and so
Okay.
they're not really coming in. They're like they came in. I got
So this is access again.
yeah. So the one guy that like comes to mind is like he'll come in and he'll say it's alcohol withdrawal, but it'll be benzo withdrawal and kratom withdrawal, and then he's got pancreatitis. And so he'll just be like, I need my Dilaudid. I'm like, I'm not giving you Dilaudid. Like, that's not happening. And he's like, well, what about, well, how are you gonna treat this? And I'm like, we're not. It's chronic, right? So like, if there isn't active pancreatitis on the CT scan, we don't treat the pancreatitis. We're like, it's chronic. I'm not treating it. We'll detox you from the alcohol.
Okay. So what medications help the most with opioid withdrawal?
So we talked about this, right? It's the clonidine and the Suboxone, and then I give you phenobarbital and Depakote for mood stabilization while you're coming off of it.
Okay.
So those are the main ones.
And what is the typical like timeline in the regimen?
I give you phenobarbital for the first like 48 hours until I can get you the Suboxone, and then as soon as I give you the Suboxone, I start it.
Do you know how long I peed dirty for phenobarbital?
Probably like a good 2 months.
Yeah.
Yeah, it takes a
Really?
while. Yeah,
Yeah. Okay. Yeah. It was like a little bit longer than 2 months
yeah,
after for 48 hours of use.
yeah.
Why?
I don't, it's like like a slow metabolite.
Yeah. Wow. That's yeah. I got in trouble over it.
Sorry.
You know, like because it was like I would pee dirt, I would pee and I wouldn't have it, and then I would pee and I would, and then I would pee and I
Yeah,
wouldn't
but the
have it.
thing is, like, no one's really abusing phenobarbital.
Yeah.
Like, that's nobody's like buying phenobarbital off the street.
I don't. Yeah. I don't know if you can. I'm sure you
Yeah,
can somewhere. So, why avoid detoxing cold turkey?
just I think you're more likely to go back to using if you just go through it because there's no constraint, there's no container, right?
Yeah.
We go back to that like on day if you're like I'm gonna quit, like we're gonna do this, and the 36-hour mark comes along and you were just miserable, right? And
Yeah.
someone's like, hey man, like over here, and you're like, oh, that sounds like a good idea, let's go do
Yeah.
that.
Definitely.
And then I also like to have a line drawn in the sand, right? Like coming into inpatient is just a line in the sand of like, hey, like I'm stopping here, and I give you 3 days of not being out there and doing the fight or flight searching and seeking thing. I mean, at some point for people, it's important just to have containment for a while, right? I mean, just going into treatment for no other reason than like I can get you 30 days away from the insanity that you were in before.
Yeah. So, how long does it typically last? And this is a weird question because it's so different. I feel like I think there
Well,
might be like an average.
Like withdrawal itself, without treatment or with treatment?
without.
Without, I think like 4 days.
Okay, then with.
With, like the symptoms go away pretty quickly because I'm managing it with the Suboxone.
Hmm.
But it's weird because sometimes they'll keep patients in detox for like 7 days, which is fine,
That's how long
right?
I was there.
Where? At our
Hmm.
detox? No, you weren't.
I think it was like I came in on a Thursday.
I guarantee you were there for
Okay,
4 days.
I came in on the 13th and I left on my birthday, which was the 19th.
That's because you went home and we
Oh
readmitted
yeah.
you.
Oh yeah, I forgot about that.
Otherwise, it would have been 4 days.
Okay.
4 days is the max. That we do in the hospital setting, right? But in the outpatient or in the behavioral health setting, it's like 5 to 7 days,
Okay.
depending upon the taper that we do and the consistency of it. But we'll sit down and we'll talk about that of what our plans for the facility are going to be.
Yeah. Okay, so
But then you got so how long does withdrawal last, right?
yeah.
So you don't have just the acute withdrawal phase, you've got the pause and all of that stuff.
Yeah.
And how long does that take and how long are your patients experiencing all of that?
Okay, so post-acute withdrawal syndrome,
Uh-huh.
pause. I've been told that it is the same regardless of the drug, and it is 18 to 24 months.
Okay, so I pause for me is a constellation of symptoms that has no biological basis.
What?
What's the biological basis for it?
I mean, so what they told me was that like this is where like the downstream uh so post acute, right?
Okay.
We're talking about like the sweats, the diarrhea, the
That's not post acute.
no, no, that
That's the
acute.
acute
Yeah, right.
withdrawal.
So
Okay.
now post acute, all of post that, like after all
Okay.
of
So
that.
that goes from 7 days to 2 years. Is that what you're telling me?
Yeah, that's what I've always been.
That
18 to 24 months,
that's recovery.
regardless of the drug
That's like so.
and regardless of the length of use.
Okay.
That's what I've been told
So
that so many times.
for me as a physician, right?
Yeah.
And I'm not talking for the American Society of Addiction Medicine, right? For me as a physician, pause is like the umbrella, umbrella symptoms of any symptom that you're having that some patient is like, Dr. Shaw, I got this going on, right? You can be like, sounds like
Post-acute
pause,
withdrawal.
man. Sounds like you're going through some pause right now, right? And like I don't like to do that to patients, right? But I remember seeing that with some of the physicians that were at the thing, and they're like, post-acute withdrawal, right? Like that's just recovery. Hey, you've got some feelings going on right now, right? Sounds really really tough. Have you called your sponsor yet? Have you gone to a meeting lately? Have you done any of those? I'm feeling super anxious, or I'm like super depressed, right? I'm like, oh, that sounds so tough, right? Like, what are you doing recovery wise?
At the exact same time.
At the what do you mean?
They're depressed and anxious at the same time.
Which is not even a thing, right?
Yeah.
Like, tell me what that is biologically. Is
Yeah.
that like? And so for me, when you get, that's why this whole thing developed. Is it none of it made sense to me, right? It was really important for me to kind of figure out why is it that these things are coming up that are happening over and over and over again. Like why is it recreatable? But there's no biological context to pause. Oh, your brain's like reshaping. Oh, you're going to be anxious and depressed for like 18
Yeah.
months. Oh, you're getting stomach problems, sleep problems. Oh, that's all pause,
Yeah. That's
right?
dude. Yeah.
Every single thing, every single symptom that you could possibly have for the first 12 to 18 months, right, is like pause. So, what is pause even, right?
That is a really good point.
Yeah, like what medically, like, can you point your finger to and be like, that's the biological mechanism for pause?
Okay, so
It's
so
just
it's really just a blanket term for like go to a meeting and call your sponsor.
it's a blanket thing for
You're
dude,
going through recovery.
early recovery sucks. I'm so sorry. I'm so sorry you are suffering right now, right? This too shall pass.
Okay.
It's basically what they're telling you.
Okay, so when is stabilization complete?
Um, Medical stabilization is complete when you are physically done with the withdrawal symptoms.
Really?
That's when I would consider medically stabilized.
Okay, what would the
So
other
you're medically stabilized to go to treatment,
Mhm.
right? And then after that is are you mentally stabilized? have we calmed down the fight or flight enough where you could possibly go back to a residence in the outpatient and not drink over it?
Okay.
And so like there's the 28 days.
Which is crazy.
Have you gotten enough time away? But then there's also sober living. So for me, sober living becomes an extension of what I would ideally love for long-term care
Yeah.
to be, right?
Yeah.
But I would much rather you be in a sober living facility close by to where you're planning on living afterwards, that you can start building up those connections and those people that you are planning on doing like later on. So
Yeah.
if you're living in Clear Lake, I don't want you living in sober living in Houston. I'd much rather you live in sober living in
In
Clear Lake,
Clear Lake.
so that you're going to meetings in Clear Lake, you're going and like connecting with those people in Clear Lake, you're living close by to where you're going to be living, so that when you actually do build or you leave the sober living, you've already got a community established for you. I've had patients relapse that were in sober living, and I was like grateful that they were in sober living, but they stayed in sober living by the treatment facility, and then they moved, and then they moved back down to like Friendswood, and they didn't know anyone there,
Yeah.
and they weren't really connected with meetings, right? So the first time something happened, they were like, "Well, my home group's over there," and I'm like,
So
"You don't know anyone down here."
you know what's funny? Okay, so for anybody who doesn't know, like where Friendswood is,
It's like 30 miles south of Houston.
dude, it is. So in San Diego, people would talk about like, oh, I got to commute to work, and it was
Okay.
like 25 miles. Right? They're like that was like a commute. And then I moved
Okay.
here and it was like, "Oh no, I'm going to go to the grocery store." It's like 15 minutes away anyway. Or like if people are like, "Oh yeah, I'm going to go to Houston." And it's like nothing. But it's like with traffic could be like 45-minute drive. And I just don't hear people complain about commuting here. Whereas like in
Oh,
California,
I
it's like,
can't stand it.
"Oh, I can't either."
I think they've become.
Numb
I
to it.
I think that Houston grew out,
Oh yeah.
right? So there's a lot of like urban sprawl of like people just disseminating all over,
Yeah.
right? From like the center.
Yeah.
Is traffic bad?
That's not even a question. Traffic is terrible here.
Yeah, I don't. So I don't live. I live inside the loop, and everything that I go to is within like a 4 mile radius, right? Like the new hospital is 4 miles away. Here is about, I want to say like 5 or 6 miles away, so it's not that bad.
Yeah. I mean, yeah, it's still like a hop, skip, and a jump. It's right there.
Yeah.
But so I am from California. I spent a lot of
Same.
time in San Francisco. You were from LA,
Yeah.
right? A lot of time in LA, a lot of time in San Francisco.
But when I was living in LA, I went from Cerritos to living on campus for like 4 years at USC. And then when I was done with USC, I moved to South Pasadena, and then I worked in downtown. So that was like about a 20-minute drive.
Yeah.
And so that was like completely doable. And I was just not having the long distance
Also,
driving at all.
that Pasadena to downtown,
The 110.
there's like very little traffic
Yep.
compared to the rest of.
Yep, I know. That's why I lived there.
Okay.
It was amazing.
Okay, you cheated. You
What?
cheated yourself out of the
LA
LA
experience?
experience.
Driving to San Diego or Santa Monica was just a hassle, and I was just like, it didn't want
Oh
to do
yeah.
it. I was like, oh.
Yeah.
Or if I would go hang out in like West Hollywood with my friends, like I would crash there. I
What
wouldn't
were you
like it.
doing in West Hollywood?
That's where my friends lived. They lived in West Hollywood, right off of Sunset.
Really?
So yeah, so we would go up to.
What do they do for work?
They worked in downtown. Or one of them went to law. Like so during.
Okay.
One of them went to law school at USC, and then a bunch of my friends went to law school, so they were like living in that area, going to law school. And then I had a friend that like lived there also. But that was the apartment that we met up at before we went out to Hollywood. We didn't go out to West Hollywood. We went out to Hollywood.
Okay.
We went out to like Hollywood Boulevard, but they lived in WeHo. Like,
Okay.
they lived in West Hollywood.
Okay. Is that the building that was right next to the clubhouse
The building that was right next to the clubhouse.
that you never went to? In LA, you said that there was an apartment building that you lived in that was right next to the clubhouse.
Oh no,
during the peak.
that clubhouse was in South Pasadena.
Oh, okay.
Yeah, like the AA clubhouse.
Yeah.
Yeah, it was right next to South Pasadena.
Okay.
Yep, never went to that.
Okay, so two-part question.
Okay.
What helps people stay through detox? And is detox possible in outpatient?
Okay, so having a plan or a commitment before you come in is really helpful because
Mm-hmm.
that way I know you're going somewhere,
Yeah.
or that you've already had a plan to go somewhere, and so you're just stopping by for detox. I really don't like detoxing people only. Like, it just doesn't feel, I don't feel good about it because I know what the outcomes of that are. I know
Mm-hmm.
how badly I know how little chance of recovery you actually have after detox, right? When someone's like, and I'll have people that have come in like three times. We have a 3 time cap.
Mm-hmm.
We won't accept anyone after the third time because it's not working.
Yeah.
And like, I know exactly when it's not going to work, when they're like, yeah, I think the first day they're like, oh, I'm going to go to outpatient. I'm going to come to your program, Matt. Like, give me the phone number. I'm going to give a call. And then, like, day 3 rolls around. They're like, I think I'm just going to go home. No, I'm okay, Dr. Shaw. I got this. I'm good. I'm like, okay. But I don't fight them, right? There's no reason to fight it. I don't have the, I, I've learned that you can't talk somebody into recovery. It
Yeah.
just doesn't work. And so I'm not a fan of that. Can I do withdrawal in an outpatient setting? Definitely I can do opioid withdrawal in an outpatient setting. The problem is that most of the patients will take the Suboxone too early, and they'll go into precipitated withdrawal.
Yeah.
And then
Which
they'll
is
then
so scary.
then they'll blame me for it. And I'll be like, I told you not to do it. So, like, I don't trust them enough to do it on their own.
Yeah.
What we can do is an induction, in an inpatient setting, or in a hospital. I'm sorry, in a clinic setting induction, but they don't stick around long enough for that, because in order to actually do the induction, you have to wait 48 hours after from since your last use, and they will never make it that long.
Isn't that crazy? It's relatively not that long of a time.
No, it's not. But it just doesn't happen.
Okay. Let's talk about harm reduction.
Okay,
Harm reduction is an interesting topic. I think it gets a really bad rap because of what's going on in
well,
California.
what's going on in California?
Well, they're bringing pipes and needles and cotton ball. They're like all of your shooting up needs get
Uh huh.
provided by the state.
Okay.
All of your
I've never experienced that here.
oh
Right?
yeah,
They
no,
don't
no,
they
no.
don't have those here.
I mean, it's illegal
Okay.
basically. Like what they're doing in California would never happen here.
Okay.
They have fentanyl test strips, which are illegal in Texas.
They're illegal in Texas.
Yes, they are illegal. They are drug paraphernalia.
I did not know that.
Yeah,
I thought there's a group of friends of mine are doing harm reduction, and they give out naloxone. I thought they gave out fentanyl strips in
I
there too.
seriously doubt it. It is
Okay.
illegal in Houston.
Then they only gave out the naloxone
Hmm.
inhalant,
Yeah.
and then clean needles.
Yeah. Okay. So that's kind of like the tip of the iceberg of what's going on in California.
Okay. So teach me about that.
So there are safe administration sites like where you can go shoot.
Okay.
Like at one time, I had never
It's
been
like
to
it's
one.
like Amsterdam, right? Or
Yeah.
like
Oh yeah.
or in where I saw that
Yeah.
special
Holland.
from Russell Brand.
Yeah, in Holland where they
Yeah.
have the safe sites.
Okay.
But they've got NGOs that go around. They have an RV full of just material and paraphernalia, and you can go like trade your old stuff for new stuff, right? And so a lot of people like think of harm reduction and they think of like providing addicts clean utensils, right?
Okay.
Or yeah, just it's got that whole stigma around it, right?
Okay.
But when I talk about harm reduction, but obviously I'm not the maker of the dictionary and I'm not the people out here that are making these definitions, but I wish that harm reduction had something more to do with like the step down process of a plan of exposing yourself to less and less harm.
Okay. Yes.
That's how I would have defined it instead of how it got defined, how it is.
I, I think like this goes back to like the stigma around it, right?
Mm-hmm.
Like, and what people are, what the perception of it is versus like what they're actually doing and what would have happened otherwise.
Yeah.
What would the normal what would it normally look like if this particular group wasn't there,
Yeah.
right? And then how many lives are you saving because they are there?
Yeah.
I don't know. I don't know the numbers. I don't know the statistics around that or any of those things.
I don't know. I mean, there's a I think there's a case that could be made either way that you're hurting people or helping people by providing them with this stuff.
I think if I kept someone long enough, they at least have a shot of finding recovery. Because once you're dead, like the game ends,
Yeah. Yeah. There's
right?
always hope. if you're still breathing.
Right. I think it's really misunderstood as like enabling, and that it's where morality and like science clash together. And I think one of the biggest fears is that they think you're normalizing the using,
Oh yeah.
and like it's okay, right? It's like we've basically condoned the fact that you're using drugs on our streets, right? And we're actually gonna make sure that it's safe for you to do it, but it's okay because we're saying that it's okay, and so then
Well,
it's a public image thing.
when you think about like the when you talk about like the spread of diseases and when
Yeah.
you talk about that kind of stuff, it's like it makes a lot more sense from that framework. But when you're talking about like from a recovery framework, it makes no sense at all
Mm-hmm.
to like provide that stuff.
Right, because I mean, the recovery perspective is a complete
Absolutely.
100% abstinence.
Right. And
Yeah,
so, that's the next question is how does harm reduction connect to abstinence?
it's just it's part of the continuum of care, right?
Hmm.
It's preventing people from dying, right? And then that safety that you create for them, and that they're not out there on the street in a fight or flight state, makes them more open to recovery or recovery concepts, or opens the door to possibly being like, hey, would you like to consider this?
Yeah.
Right? Would you like to consider this?
So
Would you like to consider this?
George Joseph said yesterday? Because we
Mm-hmm.
kind of talked about this kind of in like a roundabout way. He was like, well, instead of vans of needles and crack pipes or whatever, like bring them food. Like bring them good food. And then he talked about First Baptist where he was like,
Uh,
yeah, we used to feed them and then there was a meeting afterwards and nobody would go to the meeting. So we made them go to the meeting and then we fed them afterwards. Or like if you drove around with like some killer burritos,
uh-huh.
which I'm a sucker for. I would stay for any meeting for a killer burrito, especially because all the burritos here in Houston suck, like terrible. Hey, in LA, there was taco shops that would say San Diego style burritos. Have you seen those?
Uh-uh.
Okay.
Oh, wait, here in Houston?
No, in LA.
I like the Baja type, the
Yeah.
Baja style. Yeah, I mean, I love the like my favorite burrito is a lobster burrito, but you can't find that
Oh
anywhere,
yeah. You
right?
know what's
Like,
really good too is the shrimp burritos.
yeah,
Oh
it's
my
but you
god.
can't find that anywhere here either.
No,
Yeah.
no. It's because this is all Tex-Mex. So
Mm-hmm.
what's funny is that's all Tex-Mex too, but it's Baja Tex-Mex.
Baja Tex-Mex. Yeah.
Right. It's really interesting. Anyway, so what are safe injection sites?
I don't know. I've never seen one.
Really?
Yeah.
Yeah. So there's a couple different ways that they are done. So in San Francisco, famously, there's the ones where you inject yourself, and then there's the ones where they will inject you.
Oh, interesting.
Hmm.
Okay. And so,
There's also like testing. They'll test the drugs for you.
okay,
Hmm.
interesting. I gotta go soon, Matt.
I gotta pee.
Okay. Well, I think we should wrap this up.
Let's wrap this up.
Okay, yeah, because we went up to 3 hours.
Okay.
The
Thank you
goal,
guys.
The goal is to do it for
Two.
2.
Yeah, we did good.
Yeah. Okay. All
Okay,
right.
guys. Thank you for coming. We'll be back next week. What's our subject next week?
Ketamine, and I'm putting it all together with any psychedelics that they're using for therapy.
Okay.
So MDMA, psilocybin, ketamine,
Maps is
and
messing with DMT too. Are you gonna do that?
no,
Okay.
no, ayahuasca.
Okay.
Just to like see like what's the mechanism of action, like how are they using it, all that stuff. Okay.
Okay. All right.
All right. Thanks, you guys.
Thank you, everybody. Nate, good to meet you. Please subscribe, everybody. Thank you for liking, and I will see you next week.